Juste la partie. On m'a demandé de faire l'appel, mais vous êtes très nombreux, donc je pense que je vais faire passer la suite chez vous. En mesure votre temps. Peut-être ceux qui sont en ligne. Est-ce que vous m'entendez? Tout le monde parle français,
Oui.
donc peut-être on va. Okay, we speak in English, so people online, could you please tell me who you are? So the people that appear, I can check it out.
Monsieur, moi,
Oui.
exceptionnellement, la prof m'a autorisé du coup à être aujourd'hui en ligne.
Très bien.
Du coup, c'était juste pour vous tenir informé. Je suis du
Alors,
coup en master 2 IP.
Ok, c'est bon. Tous en ligne bancaire. On va faire l'appel pour ceux qui sont en ligne. Guard Pankaj. Myriam Motiola. Anadia. Ah oui, vous êtes bien appelé. À l'étranger. Sophie Bruguière. Et Yamina Chourou. Oui, votre nom, you have your name across here. Yes. You take your name and you just put the cross on the right column. Okay? So this is a workshop. So I guess there are 3 groups presenting 3 or no, 6 articles, right? So perhaps the best thing is I let you begin. I let you start group by group, and then after all, I will just make a brief overview of what we know about the EGFR mutant and targeted therapy, if it's okay for you. Okay, so who is group 1? Okay. Online, is it okay? Can you hear me?
Yes.
Okay. Sur l'ordi, vous le mettez sur le dos. The other 2 groups are there. Okay, you have a USB key? Okay. We'll connect sorry? Okay, okay. The second and third, you have your presentation on USB. Yes? So I can I'm Olivier Calderas, so I'm a researcher. I work on lung cancer at the CRCT. So basically I started that with Professor William Azier, who is an oncologist. So the last few years I just present myself, it's very busy. And so I'm doing constructional research, so very close to the clinic, but I'm a biologist, so researcher, I'm not an oncologist. But I work in this kind of targeted therapy, so I will have some overview of what's targeted therapy and the treatments on EGFR mutant and cancer patients. And as you will see, there are some good responders as lots of kind of targeted therapy, and one of the main problems we have is that the patient will usually relapse, so they acquire resistance mechanism. So on this presentation, we see how EGFR mutant have been discovered, what the models are to study this resistance and response to targeted therapies, and also there are some presentations about targeting resistance mechanism. Okay. And lastly, I will make a brief overview of the evolution of therapy with the focus on targeted therapies. Okay. Online, is it okay for you? The presentation? Yes, no? Online, can you see the presentation?
No.
Ah, parfait. Ah non, c'est partager. Il faut partager l'écran. Now?
Yes.
Ça?
So today we are going to present two articles about EGFR inhibitors as new targets of investigation in lung cancer. And the first point we're going to show is target validation. How did the researchers manage to pinpoint which mutations were a potential target for the treatment of lung cancer? Lung cancer is the leading cause of death, responsible for a third of cancer fatalities, killing 1.8 million people in 2022. We can differentiate two types of lung cancer based on histological characteristics: small cell lung cancer and non-small cell lung cancer. Small cell lung cancer is about 50% of cases from a neuroendocrine origin, so originating from the neural crest lineage, and is secreting a lot of peptides responsible for paraneoplastic syndrome. It responds well to chemotherapy and often relapses with resistance. The subtype we are going to be interested in today is non-small cell lung cancer, which is about 85% of cases, and is from epithelial cells airways. It often presents with metastasis and doesn't respond well to chemotherapy, with a very bad prognosis of about 1 to 2 years of survival. So the molecular targeted therapy we are going to investigate is the one targeting EGFR. So EGFR is the epidermal growth factor receptor from the tyrosine kinase family, and from the tyrosine kinase family, and made by the ERB gene. In non-small cell lung cancer, it is mutated in a subset of them and confers to the cells hyperactivated EGFR pathway, promoting cancer cell survival and proliferation. Tyrosine kinase inhibitors are the TKI are the molecules we are going to focus on today, which is works as a competitive bind to the LTP pockets, disrupting the signal and inducing apoptosis. It is already used in other forms of cancer, such as myeloid leukemia, skin and digestive carcinomas. Today we are going to review two articles. The one is the correlation between a response to TKI, gefitinib, and mutations in lung cancer, and the second one is the investigation of how the researchers managed to create a model to better study TKI in lung cancer. So EGFR mutation in lung cancer correlation with clinical response to gefitinib therapy, which is an investigation done after a clinical trial because they noticed something. So the first thing they noticed is a significant variability of response in NSCLC to gefitinib in the clinical trial. So first of all, the first method they use is they took a set of patients who were not treated with gefitinib from Japan and USA. So 74 men and 45 women, which gives them 119 primary NSCLC tumors, which 70 of them were carcinomas. They were looking for somatic genetic alterations, and especially exon encodings, the activation loop, and the phosphate binding loop, which is P loop here. They detected a subset of set of mutations. The first one is in the activation loop, the L858R, which transforms leucine into arginine. Second one is in the P loop, the G719S, which transforms glycine into serine. And third one is a set of deletions altering the area. Second method they used was to assess if EGFR mutations were conferring gestational sensitivity to the carcinomas. So the method is they took 4 cell lines of adenocarcinomas and bronchoalveolar carcinomas. 3 of them were wild type for EGFR, and 1 of them was a bearer of L858R mutation. And they are checking the response to gefitinib by immunoblast. The result is that we see less autophosphorylation of EGFR in the mutated EGFR, and subsequently we see an inhibition of phosphorylation of downstream targets such as ERK and AKT. Moreover, we see that we don't need a lot of TKI gefitinib to have a good response. Only 0.1 micromolar stops the phosphorylation of EGFR, and there is a very low IC50 in the lineage we are looking for. So we can conclude that there is a hypersensitivity of this mutation to gefitinib.
So to have a model to study EGFR mutations in a mice, they did a model, and the first model is in this article. So the title is lung adenocarcinomas induced in mice by mutant EGFR receptor found in human lung cancer, respond to a tyrannic tyrosine kinase inhibitor or to downregulation of the receptor. So to start, there are 90% of EGFR mutations are either short-in frame deletions in the 19 or exon 19 or point mutation of like we see before L. 90% of EGFR kinase subunit mutations in lung adenocarcinomas are linked to one of the 2 mutations, and to finish in 50% of cases of resistance to gefitinib or erlotinib with an inhibitor of tyrosine kinase 2. The acquired mutations is T790M in exon 20, preventing binding of the drug to the ATP binding pocket. So the objective of their study is to understand the role of EGFR mutation and in the initiation and progression of lung adenocarcinoma in vivo, and so to do it, they did transgenic mice infected by doxycycline with an antibiotic. So to make it, they used a construction with two different vectoral initiation in the mice, in the embryon of the mice. So they did one construction with the CCSP to induce the transcription of RTTA, which is in complementation with doxycycline, factor of transcription of TETO to induce at the final of it the transcription of EGFR mutated. So the first step is to have mice with one of both constructions, and then they get one mice with 2 constructions who have an expression located in only the lunge to have a localization of EGFR surexpression only in the lunge. And to control it, they did RT-PCR in each organs of the mice. And so on the control, we can see that the EGFR mutated is expressed only in the lunge of the mice. Then they control the expression of their both mutations of EGFR. So they did one model here, one model with deletion of the exon 90, and the second is punctual mutation is in exon 21. And like it, they see here that in the control, so with doxycycline, but not in the mice modified. They have not production of EGFR mutated, and we see that their model is okay. And in the second, they control that the only EGFR surexpressed is the human, that is the marker of human EGFR, LA22. And when we see here, we see that it's not expressed in a mice without construction, but it's only expressed in a mice with the construction. Next, they control their lunge of mice in a histological cut. And we see so the number of type 2 pneumocytes increasing. So their modification have the faculty to upgrade the production of type 2 pneumocytes. So this is an explication of why there are more EGFR in the mice mutated. We can see multifocal invasion of adenocarcinomas of variable size on figure G. It's complicated to see, but not impossible. We can see an airspace compression by augmentation of proliferation in the figure D. Here, so here after 4 weeks of inducing by doxycycline, and there is no tumor in transgenic mice, in monotransgenic mice. So when we put one answer without the other, we don't have the production of EGFR mutated, and no tumor in big transgenic mice without doxycycline, but they are not with the results on the article. Then article. That is yes. Okay. So after they wanted to see if they can see the carcinomas, the adenocarcinomas in with NIRM, MRI, and they did the construction like that before with ERAS, and they succeed to do it, and so they prove that it's functional with its mutation too. So with longer, we see that with a longer exposure to doxycycline, there is an increase Yes, can you
Please, online, could you please put your microphone off, on mute?
please?
Thank you.
So with a longer exposure with doxycycline, we can see an increasing of reticuloendothelial pattern and consolidation filling the whole lens of the blood. To confirm that the consolidations observed in MRI lung tissue for histology. Here, there are in white adenocarcinomas, and you see the same on histology cut, and what the MRI can be used to detect tumors, and the pattern observed by MRI correlate with tumor histopathology. Here they did the same, but they wanted to show the decreasing of adenocarcinomas with the induction of the induction of doxycycline. So we see that with doxycycline there are a lot of white mass. So it's a lot of adenocarcinomas, and without doxycycline, after 7 days off, there are decreasing of adenocarcinomas. We see that on all the construction. So with deletion of the exon 19, and the mutual mutation in the sequence of EGFR. Here is a table to summarize the treatment with erlotinib. So it's TKI inhibitor, and all of the animals that receive erlotinib at dose of 20.5 milligrams per kilograms per day showed partial to complete responses by MRI as early as 2 days after erlotinib treatment. The other important data are collectively, the data demonstrate that EGFR L8058R and EGFR, all the other mutation induced lung tumor are both sensitive to the TKI or erlotinib, and this result suggests that inhibition of the kinase activity of mutant receptor is sufficient to induce response similar to those observed after the induction of EGFR in mice and after TKI treatment of most human lung tumor with EGFR mutations. Then they wanted to have a better knowledge on in mechanism of action and what are the pathways induced by EGFR. So they took all the they took a marker of each signalization pathways. So ERK, STATE3, and AKT are 3 pathways pro-proliferative of the cellular, of the cell. And we can see that MAPK, PNPK, and STATE3 pathway are all stimulated by mutant EGFR and oncogenic KRAS during the tumor immunogenic process. So on the picture, we can see an augmentation of a diminution of the volume of alveoli of pulmonar alveoli, and but on the whole pathway, and in the down of the figure, we can see that without the discipline, we have a dilution of the volume of the cellular proliferation. So the results suggests that activation of the signaling pathway are directly related to activity of mutant EGFR. So to conclude this article, we have a great model to study EGFR mutation in mice in NSCLC cancer. It's possible to induce an LCLC on mice with this model, and it's possible to study new treatments. It's possible to study mechanisms of TKI resistance, but they did it a little bit, but it's we'll see later, but it's possible maybe to do it more often. The outlooks, so it's a good model if we succeed to study this mechanism of action, we can increase the patient survival. The use of TKI to better survival of NSCLC patients, use of TKI in other EGFR mutated cancer. It can be it can enhance detection methods for EGFR mutations to enable early diagnosis and personalized treatment plans, and it can use to focus on next generation inhibitors targeting resistant mutation like the 7019M, like osimertinib. It's a drug on the market to target directly the mutation induced by the TKI, like LT or liftinib. And the limits of the this article, it's this one. So the studies are benefits for a little part of NSCLC because it's less than 20% of of all NSCLC. It's sensitive. The sensitivity to other TKI is not shown. Can TKI targeting cellular domains work? We don't see it in this article. And if resistance to EGFR inhibition emerge, so secondary mutation is not determined, and the variation of mutations and response in different groups of people, it's another limit to this level. And it's the end of the presentation.
Thank you for your attention.
Okay. Do you have questions in the room, online? So to start with the first one, so what do you know about the rationale to develop EGFR targeted therapy? Because what you presented is that only a small subset of patients do respond to treatment, and they found that this was responsible of EGFR mutants, but the other group were treated So why did we develop this kind of therapies if we didn't know that EGFR was mutated?
Well, the clinical trial made a point, which is some people in some demographics responded well to getting the therapy, but they don't know more about how they decided to investigate.
Yeah, but why did these patients receive EGFR targeted therapy? You don't know? You have some idea?
Because they don't have all the expression of the receptors.
Yes. The initial strategy was because they found that EGFR was just overexpressed in a lot of tumors. Okay. So, but as we can see, overexpression is not enough to make the cell sensitive to targeted therapy. So this is why before they have this kind of development of therapies, and then they found that EGFR mutation were responsible for therapy. So this is kind of reverse development of targeted therapy because they didn't know the targets. They just developed the targeted therapy in response to observation. But in reality, and it's true for all the targeted therapies, they only work if there is a genetic defect and not just an overexpression of the protein. Okay. So this is kind of weird because as you can see in the second model, there is no mutation. So the mutation is induced, protein is induced, but this is not a genetic defect of the cells. It's an overexpression, but it's overexpression of the mutant protein, always the mutation. It's always the same for all the targeted therapy. There is ALK translocation, there are KRAS mutation, MET amplification. So if you have just an overexpression of the protein, it's not enough to use targeted therapies. This is why we just put up on the genetic basis of the tumor. So we can just jump on your limits on the third one. Can targeted therapy target extracellular domain? What's your feeling? What you say?
But it's if we
The TKI used in those articles are targeting intracellular domains and are very specific to EGFR. So researchers were wondering if more general TKI targeting extracellular domains were going to work as much as intracellular TKI targets.
But what would be the rationale to target extracellular domain, the EGFR? The rationale, what the idea? Because we know that the phosphorylation and ATP activation is inside the ATP domain. So for the signaling pathway, it makes sense that we block this particular site of the receptor. What would be the rationale to block outside in the extracellular domain?
Well,
it's possible to increase the development of EGFR antibody.
Yeah, the question is, how do you think it could work if you block the extracellular domain?
work as an antagonist of the receptor.
With the ligand, EGF,
Yeah.
antagonist of the receptor with this ligand. Yes, yes.
How could be you? Do you understand what can be the mechanism of action of inhibitor?
We have the receptor, it's here, okay? EGF receptor, so the EGF is a ligand, so it stimulates the receptor and then the activation of the pathway is, okay? Now, we know that the mutation is here in the ATP domain, so we have blocked this. But if you block the extracellular domain, what you do is just to block the EGF on the receptor, right?
Yes, right.
But we know that the mutation does not need EGF, okay? So if you just block outside, you just block the signaling of the EGF on its receptor, but if the receptor is mutated, then you have no effect outside. So the only rationale to target extracellular domain could be by targeting with ADC, you know, ADC. Okay, so that could be used, and this is used, for example, in R2, mutant, but not yet in EGFR. Okay. And what do you mean about variation of mutation and response in different groups of people?
Well, that's what they were saying in the first article, is that they took people, especially from Japan and from the US, because those were people who were responding very well to the treatment. But in European or African descendant groups, that it wasn't the same. The mutation wasn't as present as in the other groups.
So just the proportion that varies.
Yes, proportion is.
But now, do you know which kind of people are treated here in France, for example?
What is the question?
What the test to say that this group of people will be treated with this kind of therapy?
Is the test of PCR to see the mutation of GFR
Yeah, for example.
or the CKI.
For example, of PCR, now we can do sequencing with NGS. So we have panels of genes. When the patient enters, you can just check whether they have some mutation. If they have some mutation on L858 or a deletion on exon 19, then you can put this group on treatment. Yes. But the reason why Asian people or Japanese people have more proportion of this kind of mutation, we don't know.
Right. And why there is only and why there is only on.
Well, this is a bit more known yet now, because we know that this kind of mutation is more related to non-smokers.
Yes.
And in the middle of the two in 1940 and 1930, women didn't smoke. So this is why more men have non-EGFR mutation, for example, KRAS. But now it's like women smoke, so there is a less proportion of this kind of mutant in women. Okay, but we have the same pattern, for example, in ALK mutation or ROS mutation, or MET amplification. So if you come to the clinic, a woman that has never smoked, we are probably sure that there will be an EGFR mutation or ALK mutation. For smokers, it's more small cell lung cancer or KRAS mutants. So question about the mouse model. So one thing you didn't explain is why is it specific to lung, this model?
Because they use the induction of transcription only active in the lung.
Yes, which part of the system is only activating in the lung? You spoke about CCSP, but
yes,
yeah, but you didn't describe what CCSP is.
CCSP, the protein is only produced in the lung, but
it's Clara cell specific protein.
Yes,
this is a protein that is only expressed in Clara cells. But they just observe that it's obviously just in the lung because Clara cells are part of the lung.
yes.
But at the end, what we can see, there is hyperplasia and adenocarcinoma and type 2 pneumocytes. These are not Clara cells. So this is like a bias of the model.
Can you repeat it?
Yeah, CCSP.
Yes.
So do you know the
Yes.
lung?
Yes.
In the lung, we have different types of cells. We have alveolar cells. We have the pneumocytes, type 1 and 2.
Yes.
There are also another type of cell which is called Clara cell.
Yes.
Okay. So at the beginning, they just wanted to overexpress CGFR in Clara cell.
Yes.
But at the end, what we have is an overexpression in also type 2 pneumocytes. So it's derived from this transcription. It's not only expressing Clara cell. This means that Clara cell can evolve to pneumocyte type under overexpression of this construct. But initially, it was not developed for activating EGFR in type 2 pneumocytes. Otherwise, they would have used a promoter directly targeting type 2 pneumocytes.
Yes. but it works quite good.
Yeah, sure. We're lucky. And do you have some comments about this model? Because what we know about development of cancer is that there is a succession of different steps. Okay, you know that there are mutation on oncogenic driver, but there are also inhibition of regulatory protein like p53 or retinoblastoma. Okay, we have also epigenetic modification. So this is what we learned. Yes. Okay. So in this model, we have nothing. We have just overexpression of an oncogene, and it looks like it's enough to create a tumor and a sensitivity to the drug. So it's like the first evidence that only an activation of an oncogene without deleting p53 or any other event can drive oncogenesis.
It's our own model to show this congenic edited model.
Sorry?
It's only animal model.
No, now there are more. There are Kira. You can induce also.
Yes.
With now we have a CRISPR-Cas9 model to induce deletion or mutation in the cell. But this was one of the first that described this kind of model in mind. This is why we selected the present. Okay. No more questions. Was it clear for everyone? Yeah. Okay. So we can switch to the second group. Online, can you see the screen?
Yes.
Okay. The clothing down with that page. Chloe with page. Without with. Okay.
So, hello everyone, we're also going to talk about EGFR and lung cancer, but we're going to focus on its targeted inhibition. Okay. Lung cancer accounts for 1/3 of all deaths from cancer worldwide. There are two types of lung cancer. 15% of lung cancer are small cell lung cancer and originate from the northwest, and the others are non-small cell lung cancer. and have a long epithelial cell origin. Unfortunately, this type of cancer is often detected at an advanced stage, and the median survival is around 4 to 5 months per treatment. So NSCLC is divided in 3 subtypes based mainly on the morphology of the transformed cells. So lung adenocarcinoma, which is the most frequent subtype, lung squamous cell carcinoma, and large cell carcinoma. And for this presentation, we're going to focus on NSCLC. So to treat NSCLC, surgery, chemotherapy, radiotherapy, immunotherapy, or targeted therapy may be used alone or in combination. And today we're only going to talk about targeted therapies against EGFR.
EGFR is the epidermal growth factor receptor. It belongs to the ERB family of transmembrane receptor tyrosine kinase. As you can see here, it is composed of 3 domains and an extracellular domain that binds the ligand, a transmembrane domain, and an intracellular domain that allows the signal transduction. Activation of EGFR takes place in several stages. First, the ligand binds to the extracellular domain, which leads to the dimerization of the receptor and the autophosphorylation of the intracellular domain on tyrosine residues. And finally, this will lead to the activation of many pathways, as you can see here, and all of these pathways will lead to cell survival, proliferation, and migration. So you can easily imagine that a dysregulation of EGFR can cause oncogenesis mechanism. And this is what happens in NSCLC. Indeed, EGFR can be overexpressed, amplified, and also we find somatic activating mutation in 10 to 20% of patients suffering from advanced NSCLC. And these mutations lead to a ligand-independent activation of the receptor. They occur in exon 18 to 21, which correspond to the tyrosine kinase domain of EGFR, and they are clustered around the ATP binding pocket of the enzyme. Some tumors are called oncogen addicted, and we can define it by the phenomenon by which a tumor cell can become completely dependent on a single oncogenic pathway for its proliferation or survival. So this means that these tumors will be highly susceptible to TKI-induced apoptosis. Based on this model, you can see that an oncoprotein can produce 2 types of signals: a pro-survival signal in yellow and a apoptotic signal in red. You can see on your left that when the oncoprotein is activated, the pro-survival signal takes over and enables the cell to survive and to proliferate. But if we inactivate the oncoprotein, there is a shift between the two signals, and the short-lived pro-survival signal will decline first, whereas the long-lived pro-apoptotic signal will persist. And we called it the oncogenic shock, which is the period during which pro-apoptotic signals exceed pro-survival signals. So here's the question of our presentation is how to target EGFR in NSCLC. And we can use tyrosine kinase inhibitors that are small molecule inhibitors that can be reversible or irreversible. For example, gefitinib is the first generation TKI that is a reversible inhibitor. The mechanism of action is simple. TKI made a competitive inhibition with ATP here to the phosphate binding loop of the ATP binding site in the intracellular domain of EGFR. So ATP will no longer be able to bind in the intracellular domain, and autophosphorylation will be impossible. So this will lead to an increase in apoptosis and a decrease in proliferation. Among all the mutations that have been identified in lung cancer, some are associated with resistance. For example, we have T790M, which is found in 50% of the patients. And we have also mutations that are associated with a higher susceptibility to TKA. For example, deletion in exon 19 and the substitution of arginine to leucine at codon 858. And you can see here a clinical trial comparing gefitinib, the TKA, with chemotherapy in patients with EGFR mutation and in patients without EGFR mutation. And you can see that the PFS of patients treated with gefitinib is higher than the PFS of patients treated with chemotherapy in patients with the mutation. And it is the contrary for patients that haven't a mutation. So this shows the importance of knowing the patient's molecular profile when deciding on treatment. And here we can say that EGFR is like a biomarker prognostic. Among the two publications we had to present, we had a clinical trial comparing erlotinib, a first-generation TKA, with chemotherapy. The novelty of this clinical trial was the fact that it has been made on an European population, because at the time of this clinical trial, we had only data on the Asian population. So the aim was to test the efficacy and safety of erlotinib compared with chemotherapy in first-line treatment of European patients with advanced NSCLC and EGFR mutations. It is a phase 4 randomized multi-center and open-label trial. So patients had to be adult with an advanced NSCLC and a mutation in EGFR, such as exon 19 deletion or L858R mutation in exon 21. And they must not have a history of chemotherapy for metastatic disease. At the beginning, more than 1,000 patients were assessed for eligibility, but only 174 were eligible for randomization. And at the end, and 86 received erlotinib and 87 received chemotherapy. Here in this clinical trial, the primary endpoint measured was the progression-free survival, which is the time elapsed between the date of the randomization and the date on which disease progression was observed for this. So here you have the results. You can see in red the PFS for patients treated with erlotinib, and in blue PFS for patients treated with chemotherapy. And you can see that there is a significant difference between the both. Indeed, median PFS for patients treated with erlotinib is 9.7 months, and it is 5.2 months for patients treated with chemotherapy. So this shows you the greater efficacy of erlotinib than chemotherapy. And regarding the adverse events, almost all the patients developed them. So overall, this clinical trial confirms the usefulness of detecting the presence of the EGFR mutation in order to use erlotinib as first-line treatment, as the latter is more effective than chemotherapy and does not present increased toxicity compared with chemotherapy in an European population.
The treatment with TKIs appears to be effective. Post-treatment resistance is observed, and in the second publication, the authors aim to identify who patients with NSCLC with EGFR mutations develop EGFR TKI resistance and to understand the mechanisms of acquired resistance. So they are therefore carrying out genetic and histological analysis of tumor biopsies from 37 patients with drug-resistant NSCLC carrying the EGFR mutation, and patients responded to treatments with erlotinib or gefitinib that eventually developed progressive disease. So first, 37% of post-treatment EGFR TKI tumor samples are therefore analyzed for the presence of genetic alteration using a clinical genotyping platform, and the prevalence of the EGFR TKI resistance mechanism is illustrated in this pie chart. Pre- and post-treatment samples are compared to identify acquired resistance mechanisms, And the authors know that 49% of NSCLC patients acquired the EGFR exon 20 T790M mutation, and that subset developed concomitant amplification, GFR amplification. 5% developed an amplification of MET, and 5% developed a PIK3CA mutation. And 14% of patients transformed into SCLC. And you can see in orange parts a patient who transformed into SCLC and developed a PIK3CA mutation. So, however, 30% of the mechanisms are still unknown and could also distribute treatment to treatment. So next, they carried out a longitudinal study of patients repeatedly treated with erlotinib and performed repeated biopsies during the course of 2 patient visits in order to observe longitudinal phenotypic and genotypic changes in response to EGFR TKIs. And you can see that patient A suffers from lung adenocarcinoma during the EGFR L858R mutation and the P53 tumor suppressor mutation. And we can see that he had modest response to chemotherapy, then responded persistently to erlotinib before developing a resistance. And lung biopsy revealed an adenocarcinoma with a new mutation, and the acquisition of the T790M mutation. So the patient did not respond to subsequent chemotherapy, but after 10 months without being treated with the erlotinib, a second biopsy revealed that the mutation acquired was not detected. So the patient B had an adenocarcinoma with the same EGFR mutation, and this showed a marked response to first-line erlotinib. But after 1 year of treatment, he developed a resistance, and a lung biopsy showed that he transformed into SCLC and acquired a mutation. And after 7 months without exposure to erlotinib, ultrasynthesis revealed the original adenocarcinoma with only the EGFR mutation. And we can see that retreatment of the patient with erlotinib induced a second resistance, again with the transformation and the acquisition of the mutation. So taking together, these results show that continuous treatment with TKI induces selection pressure, leading to the acquisition of resistance, but also that when the treatment is stopped, patients become resensitized to the TKI. Overall, these studies show that the detection of the EGFR mutation enables erlotinib to be used as first-line treatment, which is more efficient than chemotherapy, and that TKI's treatment can induce histological and genetic changes in NSCLC. So these changes, such as the acquisition of various mutations, make patients resistant to TKIs. And finally, when the treatment is stopped and replaced by chemotherapy, the cancers are resensitized to TKI. So today, TKI treatment for patients with EGFR mutation results in improved quality of life, better PFS, and improved symptoms, and the overall administration is also an advantage. However, not all the mechanisms of resistance to TKI are known and need to be explored in order to guide patient treatments. So it's essential to know the molecular profile of patients in order and to find new treatments in order to overcome the resistance. Current TKI resistant mutation methods have limitations in terms of sensitivity, and combined more sensitive approaches such as the development of new and more efficient detection methods are needed to overcome these limitations. But resistances are problematic and could be overcome by various strategies. In particular, second and third generation TKIs are developed to specifically target resistant mutations such as the osimertinib, targeting the EGFR T790M mutation. And in addition, it will be possible to target alternative pathways activating gene resistance, such as the PI3K1823 pathway, in order to resist themselves to TKI. And the development of irreversible multi-target TKIs could be possible. Finally, analysis of circulating tumor cells could enable early identification of resistance mechanisms so that treatment can be adjusted appropriately. The new generations of TKIs need to be constantly developed to overcome emerging resistance, and it's important to know that they are constantly being discovered, which are more and more efficient. Thanks for your attention.
Questions? Line? Yes.
And maybe I didn't on board, but what was the median follow-up in the first 2 years? You know?
It's not the median PFS.
Sorry?
You want the median
Median follow-up.
I don't remember, but it's many years.
That's what you show in the graph, 36 months.
Yes.
Yes.
Yeah, I had a comment saying like normally they should have less side effects when they are receiving the target therapy, but from this figure they feel like they are particularly non-significant, like with the adverse events.
Yes.
Like the percentages to have why like usually they should have less side effects when they are doing target therapy.
Have left.
But like with 99%, 98.
Which one do you
Like,
are you looking at?
95, 99, so there are so how the things.
No, any adverse level, all the patients will have some kind of elements, but we have graduation about the severity of the element. If the element is really hard for the patient, you know, too many grades. This is why we only focus on grade 4, because grade 1 is just you have an headache, okay, so this is not that bad. Grade 2 is more severe, but grade 3 and 4, this is when the clinician decides to stop the treatment for. If there are less at grade 3 and 4, this is well much tolerated. For any therapy happens.
Yeah.
I have a question about the panel with the patient. How is it possible that they lost temperature? Do you have an idea of? It's a good question. How is it possible that they lose the mutation that they gain? Maybe there is a reason.
Maybe it's about the mechanism to repair the mechanism of the result. But
So not mechanically, but what can you imagine of the tumor developments, the treatments? Why are there some mutation appearing and then disappearing?
it's a kind of selection.
Yeah. This is just question of selection. If you lose the question, if you lose the selection, and then this mutation is not required anymore. But it has been studied in cell line. For example, you treat the cell line with the targeted therapy, you can create this mutation, but then if you start the treatment, you just wait several months and then you lose the mutation. It's not required anymore. So in this graph, so okay, the first one you say is it's really easy to understand. You have the first mutation, then you have a secondary mutation on the EGFR. So the secondary mutation, what the point is that the treatment is not able to bind the target anymore. Okay, so the T790M mutation is just that erlotinib is not able to bind, so the receptor is active. Okay, so we can the cell can use this pathway for proliferate and survive. Okay, but in the second one, you still have the mutation, okay, but you have a second mutation. This is called the bypass pathway. Okay, so what happens here is that the treatment is still efficient on the receptor. Okay, need is still binding to it, and the pathway is inhibited. But there is another pathway that activates proliferation. Okay, so what can you say about oncogenic addiction now?
Now oncogenic addiction has disappeared.
Yeah. Right? So there is no more oncogenic addiction. Okay, and this is one of the first characteristics of this kind of response. Is that we always believe that the primary oncogene creates an oncogenic addiction, but in most of the cases, and more now with osimertinib and we receive the new therapies, the cells just don't care of the primary oncogene. Okay, they just have to proliferate. So this is not really an oncogenic addiction. This is a proliferation addiction. They are addicted to proliferation. Doesn't care where the stimulus comes from. Okay, so this is something that's quite new in the field. We are studying what kind of addiction have the tumor cells. They are not addicted to the primary oncogene responsible for the development of the disease. But once the disease is established and the tumor is aggressive, now they just don't care. Okay, it's like the source of energy. We have electricity, and they switch to another kind of energy. They don't care. Okay. Can you go back to the curves? So I will ask you the question I asked all the time. Yes. Okay. So how can you describe the PFS? What represents this curve?
This is
The Kaplan-Meier curve.
yes.
And when the curve is dropping one.
Yes, it's the can I say it in English?
Yes. I can do it in English, I'm sure.
Non, enfin, dès que ça descend, ça veut dire que la maladie a progressé, qu'on a des nouveaux symptômes. So this is as progress. Patients have new symptoms.
Yeah, so progression-free survival is survival without progression. Okay, free survival. Okay, so when the curve is dropping, so this is true for every graph you will see in this kind of trial. Okay, the curve is dropping, the patient has relapse. Okay, basically. So here we can see that patient relapse much later with the erlotinib than with chemotherapy. Okay. But now what the difference with overall survival? You know that? Yeah. So this is the second curve that are not shown here, but it's what the overall survival is.
Overall survival, the curve decreases when someone died.
Okay.
And then not only about cancer, also.
Yes, it's usually by cancer, but yeah, I have a car accident and it looked like here because we don't know if the car accident is due to the cancer or anything else. Okay, so when the patient died, usually from cancers, the curve drops. Okay, now, do you know what the difference in overall survival in these patients?
They didn't find a significant difference.
Okay, and why? Do you know why there is no difference in overall survival?
Maybe I have an idea. Patients treated with chemotherapy, if they had progression of their disease, they were treated with avastinib in the second line.
Yes, exactly. So this is the reason. The patient that relapsed to chemotherapy, we just don't let the patient relapse therapy. And we offer the best second line therapy, which is erlotinib. Now what we have, so this was for erlotinib. Now in the next generation, it looks like the targeted therapy is best for overall survival for patients than chemotherapy. But in this case, it was not. So when the patient relapsed with the first therapy, we treat with the second one, which is efficient. So what's the best? It's to treat patients with chemotherapy first and then erlotinib first, and when they relapse chemotherapy. We just answer that first.
The best is to treat with the third generation.
With this study, we cannot answer that because there is no best and no. We just have to offer patients some kind of therapy. But yeah, we just have to look more about new generation to have less adverse disease, grade 3, grade 4, the prolonged survival. Okay. More questions about the plasticity? So this is something very strange, and this was appeared just with the targeted therapy. We can see with new targeted therapy, but non-small cell lung cancer and small cell lung cancer is really two completely different diseases. And small cell lung cancer do not have EGFR mutation, never. Okay. So now for the first time, we can see patients with small cell lung cancer with EGFR mutation because the tumor have evolved from one phenotype to another one. But the small cell is neuroendocrine, so this is not the same cell. So we can see that when we treat these cells, there is a reprogramming of the cells that maintain some characteristics, the mutation, primary mutation, but they switch to another kind of phenotype that is more resistant. And they do respond to chemotherapy for small cell lung cancer. This is very surprising. And we don't know yet exactly why. We know that small cell lung cancer have retinoblastoma deletion, all 100%. But why, we don't know. So what do you say about the drug holiday? When you stop treating patients with the therapy and they reacquire sensitivity to the drug, is it something you can apply in the clinics?
I think it's complicated to explain to patients. We will stop its treatment. So
you never let the patient without treatment, but switching from one to another.
But if it's a better way to cure the patients, I think we have to do it.
Exactly. So this is not really usual. So sometimes when you treat the patients and they relapse, you can offer some chemotherapy or radiotherapy. You can try therapy, and patients can respond to this treatment and then re-challenge to the first one. So sometimes it looks like it's efficient. This is something, yeah, it's done in clinic. Okay. No more questions? No? Okay, yes.
Can you the drug holiday?
When you stop the drug holiday, and the drug is going on holiday, and you change with another one. So you treat with the erlotinib. Can you show the graph? So you treat with chemotherapy, then erlotinib, and then if you treat with chemotherapy, it's like erlotinib holiday. Okay. Drug holiday is you switch from one treatment to another one, and then sometimes the tumor can be sensitive again because they lose the resistance mechanism. Okay, thank you.
Non, c'est bon.
Okay. Online, can you see the screen?
Yes.
So,
So now we'll be discussing the third generation inhibitors in non-small cell lung cancer and the new resistances that are associated with such. So non-small cell lung cancer in general is among the most common cancer in the world. It is the case for men as it is for women. It is also associated with a poor prognosis and is one of the deadliest. And in France, it's the first cause of cancer of death by cancer. So there are different kinds of lung cancer. They are different from the cells from which originate the disease. There is a small cell lung cancer that represents 15% of the population that has lung cancer. There is also a non-small cell lung cancer that represents 85% of the people that has lung cancer. And among non-small cell lung cancer, there are also 3 different kinds of lung cancer. And the most common is lung adenocarcinoma that comes from the cells that produce the mucus inside the lungs. So when a patient with non-small cell lung cancer is diagnosed, he is often at metastatic state already. And metastasis can go to the brain, and so the survival rate for such patients without treatments is up to 5 months.
Against this backdrop, the advent of targeted therapies has been a great deal of optimism in this cancer because of the approval in 2003 of targeted therapies with small molecule inhibitors of the tyrosine kinase receptor EGFR, which is an oncogene addiction in this cancer with 2 main limitations on exon 19 and 21, coding for the intracellular domain that regulates 2 signaling pathways such as MAPK or PI3K-AKT, which regulates mainly angiogenesis or apoptosis, and that's why those patients with EGFR mutant sensitive can be treated with anti-angiogenesis factor or tyrosine kinase inhibitors, such as the first generation of tyrosine kinase inhibitors targeting the mutation of EGFR with gefitinib or erlotinib, and becoming the standard treatment for those patients over chemotherapy with revolutionizing long-term survival for those patients with well good responders. But however, in 50% of cases, they develop a new acquired mutation, the T790M EGFR mutation, and this pushes the researchers to develop a 3rd generation of tyrosine kinase inhibitors, such as the osimertinib, to target this new mutation. But is osimertinib a more effective first-line treatment in this NSCLC cancer advanced?
And so they have made a clinical trial using osimertinib, so the 3rd generation irreversible EGFR inhibitor that can target the most common EGFR mutation, but also the resistant mutation T790M. And so they have used 556 patients with untreated advanced NSCLC. So that means that osimertinib will be used here as a first-line therapy treatment. Because it is already approved worldwide as a 2nd-line therapy for patients that already have the T790M mutation. So they have either treated their patient with standard EGFR inhibitor, so gefitinib or erlotinib, or with osimertinib in a double-blind clinical trial. And so what the clinical trial shows is that the median progression-free survival is enhanced with osimertinib treatment. That it is 18.9 months compared to the standard inhibitor, that is 10.2 months. And also that is the case with the patients that had central nervous system metastasis, because the median progression-free survival is 15.2 months compared to the standard use of that is 9.6 months. The overall survival at 18 months has also been measured, though very close, it is still increased with osimertinib. It's 83% with osimertinib and 71% with a standard EGFR inhibitor.
While osimertinib is demonstrated in this clinical trial as the most effective tyrosine kinase inhibitors as a first-line treatment, it also demonstrates that it induces less severe adverse events like grade 3 or higher, with most frequently rash or acne than the previous tyrosine kinase inhibitors. And all these results in this clinical trial put researchers to put osimertinib as a first-line treatment in this NSCLC advanced cancer. And one major advancement in this management of those patients is that osimertinib can cross the brain-blood barrier so that it can treat it more with more efficacy the patients who had brain metastasis, which is a very bad prognosis in these cases. Also, however, we can do most efficacy tyrosine kinase inhibitors for those patients. They always develop a relapse with mechanism of resistance, and drug tolerant cells always survive with those treatments.
One of these mechanisms is the reactivation of the MAPK pathway with ERK1/2. And that's why even today, they use a dual therapy with the combination of osimertinib with a trametinib or a serolitinib treatment, which targets this mechanism of resistance. But however, we still observe relapse in this patient after 1 year with a small percentage complete response. And that's why this article aimed to develop those mechanisms of resistance.
So the challenge in researching and developing therapeutic strategy lies into the understanding of the resistance mechanism. And that article that we're now going to present was written in 2020 and aims to understand the resistance mechanisms of the cancer cells to evade the apoptosis induced by EGFR and MEK inhibitors. So first of all, they've used PC9 cells, which are human lung adenocarcinoma cells, which with an exon 19 deletion. And what you can see that upon the dual therapy, so with EGFR and MEK inhibition, there is almost no congruency of the cells. But what they could see was under microscopy, they could still see remaining cells. And so they have qualified the cells at dormant states, because when they withdraw the treatment, you could still see a regrowth of the PC9 cells even after the double therapy.
The authors were able to determine the reactivation of the two signaling pathways by EGFR, so the P3-AKT and the ERK reactivation we see before, in those dormant cells who were still sensitive to the treatment even after a re-challenge, and they have the same morphology than the untreated cells. So the authors want to characterize those dormant cells induced by the dual therapy, and the GSER analysis shows differential expression of genes with mainly a downregulation of cell cycle genes expressions and an upgrade expression of genes associated to senescence. So that's why the authors want to confirm that senescent state of cell induced by the dual therapy with three characteristics, like the beta-galactosidase associated to senescence quantification, which is increased significantly with the dual therapy induced, like the brand H3K9 trimethylate, which is a brand that mark all the untranscribed gene in the genome, and associated to an enrichment of senescent genes, which puts the authors to confirm that those dormant cells acquired a senescent state by dual therapy.
And so then they wanted to assess the epigenetic changes of their cells. So they used the attack sequencing as a method for that, using transposase activity to integrate itself into the open chromatin, and then sequenced the genes that were into that open chromatin. And what you can see with that figure is that upon the osimertinib treatment, the epigenetic profile of the cell is different than with the combined therapy, and is also different from when they have washed out the drugs that they use. So there are different epigenetic profiles onto the cells, and also it is reversible. And among the upregulated genes, they could find an enrichment motif for the TET transcription factor family binding sites. So TET, along with YAP, are effectors of the Hippo pathway. And when the Hippo pathway is active, there are upstream components of YAP that will phosphorylate it and then induce its degradation. Therefore, the YAP targeted genes will not be transcripted. But when it's switched off, YAP and TAS can go into the nucleus complex with TET and then activate the transcription of the targeted genes. And so in the dormant cells, what they could find was that there were a higher YAP-TET signature, and they confirmed these results with a higher gene expression of the targeted genes of the Hippo pathway. So the dormant cells have different and reversible epigenetic changes, and also an increased YAP and TET activity. So to better assess the role of YAP, the authors have used combination inhibition of EGFR, MEK, and YAP with EXAV 939. And they could not see any regrowth of the PIS9 cells as they could see with only the EGFR and MET inhibition or EGFR and YAP inhibition alone. They have also done this observation with the withdrawal of the treatment on the PIS9 cells. When they knock out the YAP1 genes, there are no regrowth of the cell, and it was the case for the control cells that still had the YAP gene. So the establishment of the dormancy after the inhibition of EGFR and MET is dependent on YAP activity.
Then the authors want to follow the YAP hippo pathway activity with the induction of fluorescent reporter on those PC9 dormant cells to follow the YAP activity under live cell imaging. And they shown that a dormant cells with a YAP high activity is correlated to an inhibition of the caspase-3-7 activity, correlated to an apoptosis level, even if at the start we can see a proportional growth of apoptosis linked to YAP activity. But we can see that the YAP high activity in those dormant cells is related to an inhibition of apoptosis, and they confirm those results by two approaches. Even they first do a trial therapy with the inhibitor of YAP activities and with YAP1 KO on those dormant PC9 cells. And they show that with the inhibition of the YAP gene, we can see an increased significant of apoptosis in both approaches that is rescue with the re-expression by a lenti-vector in those dormant cells of the YAP gene. And finally, they saw that the dual therapy inducing dormant cells select the YAP high cells, depleting the YAP negative cells in the population of the minimal residual disease. And all these results putting researchers to say that ERK1/2 reactivation and YAP activation are two distinct mechanisms of resistance in those dormant cells induced by osimertinib and trametinib, and that's YAP activation on those cells, making them escape from apoptosis and promote survival signals. And then it's a vulnerability to exploit it with the development of new targeted therapies with a specificity target those dormant cells that escape for precedent targeted therapies. And the authors first confirm all the results they do in vitro with two in vivo models. First, the xenograft mice with PC9 transplantate, or GEM mice that induces a spontaneous NSCLC tumors with the recombinase. And in vivo, they analyze single-seq RNA-seq to confirm that those dormant cells, like in vitro, have an increase of YAP activity associated those senescent cells, and that YAP activity is correlated to an inhibition of apoptosis even in vivo.
So to better understand the mechanism by which YAP will decrease the apoptotic process, the author have watched the BIM protein expression. So BIM is a pro-apoptotic protein that will sequester anti-apoptotic proteins and will also activate BAX and BAC and then induce apoptosis of the cell. So what you can see now is that the EGFR proteins signaling will not change between the control experience and the YAP1 knockout cells. And also the inhibition of EGFR will increase the BIM protein level. And that there are no difference between the control and the YAP1 knockout situation. Therefore, YAP will affect the apoptotic process, but that is independent on the EGFR signaling and also downstream of BIM. So then they took those YAP1 knockout cells treated with the dual therapy and made an RNA sequencing to see that there were BMF upregulation. So BMF is a non-factor of the apoptotic process too, because it can code for pro-apoptotic protein BH3 only that will sequester also anti-apoptotic proteins and indirectly induce BAX activation and then induce apoptosis along with the inhibition of EGFR.
So all of these results were expected, but to make sure of it, they made a review experiment. Using only OT treatment with the YAP1 knockout cells, you can see an increase on the BMF gene expression. But when they reintroduced YAP wild type gene, they had a decrease in the BMF expression, but no longer, and that is also interesting, with a YAP mutation on its binding site to TED, meaning that YAP along with TED are important for the BMF expression, so to suppress it. And then to link it with the apoptosis, they made that experiment with the YAP1 knockout cells. There is an increased apoptotic rate that decreased when they use the small interferon against BMF. So the BMF induction without the activation of YAP is sufficient to sensitize the EGFR mutant NSCLC to apoptosis. So the dual therapy will activate YAP and TED that will inhibit the apoptosis to enhance cell resistance and escape.
Then the authors want to demonstrate how YAP suppress the expression of BMF and so apoptosis. And it is known that YAP is a mediator of the EMT program, and so with SNAPE, SUG, TWIST, and ZEB, and that EMT is a mechanism of resistance known in NSCLC cancer. And they confirm that there is a complex between YAP-TED and SLUG, mainly with qPCR, and they confirm it with an SC-RNA approaches inhibiting YAP or SLUG, and we can see an overexpressed BMF expression in those dormant cells, which is correlated to an increase of apoptosis in those cells. And they confirm this complex of three molecules, which is YAP, TAD, and SLUG, that link with ChIP-seq on the promoters region of the BMF gene, not directly, but they link those complex into the BMF expression. And finally, they demonstrated all the mechanism of resistance induced by osimertinib, with the complex of YAP, TED, and SLUG on the downregulation of BMF, responsible of the downregulation of apoptosis, even induced by osimertinib in the dormant cells. So it opened new therapeutic strategies to develop to have a synergy effect, to have a more efficacy on osimertinib and previous treatment existing as the first-line treatment today.
So in these papers, they also made pharmacological studies inhibiting TED to decrease YAP and TED activity. And so they have developed an inhibitor that is MYF-0137 that will bind covalently to TED by its cysteine 259. And along with other tests, they could see that the apoptosis rate was increased upon the triple therapy, meaning EGFR and MEK inhibition along with YAP inhibition, or EGFR and MEK inhibition along with the TED inhibition.
So to conclude all these results, the dual therapy induces the YAP activation and the selection on the pool of dormant cells of the YAP high activity cells, which can downregulate the BMF gene to have a resistance mechanism to avoid apoptosis induced by osimertinib and previous treatments, and then to promote survival. But this article is a perfect example of studying mechanism of resistance and adapted to develop new targeted therapies such as the MIF therapies, which is suggested as a therapy treatment to counterpass this mechanism of resistance and promote the apoptosis signal in these resistant cells, which are senescent.
So then they have proposed different combination of therapeutic strategy using all the time, every time the triple therapy at some point. And what is interesting that there is no regrowth of this 90 as long as they use the triple therapy. So they have proposed that the triple therapy could be used transiently first, and then use a dual therapy as a maintenance. So now we can ask what will happen in preclinical studies that could perhaps lead to clinical studies. And so this article was scientifically robust with many experiments, many models, many cell lines. And what is also interesting is that YAP can compensate KRAS loss on the KRAS mutated NSCLC and also on the pancreatic adenocarcinoma. So maybe it could be great to study the YAP-TED activity on other kind of cancers. And also YAP has been shown to be increased along with the AMT, so maybe it can induce the epithelial mesenchymal transition. So that could be good too to study. And it is also important to understand that there might also be other resistance mechanisms along with YAP and TEB activity on the minimal residual disease cells. Thank you.
Lot of questions. Where did you find this graph?
Your colleague,
Which one?
Monsieur Mazière.
Ah. No question? A lot of questions. So about the first part, so they compare the imertinib and other teams. So now there is no more evolution. We have like reached the best therapy since you remember 2014, I think it was
2015.
the first publication that
Yes, 2015.
14 the cancer discovery paper that showed that polymertic modification. So like 10 years after the discovery of the T790 mutation, 10 years, but and now we have reached this best response. So patients are still treated with osimertinib. So what can we say about the generation of resistance between EGFR standard therapy and osimertinib?
There is all the mechanism of resistance, like the MET amplification, the M2 amplification, or like we said, the plasticity of cell changing type of cancer.
Yeah, I will have to say that it's mainly the same group of resistant mechanism, but not organized exactly the same. So with erlotinib, we did have some MET amplification, but less. We have more EGFR mutation. So mutation on the EGFR. Now there is less mutation on the EGFR. We still have some third mutation, so 790S mutation or other mutation, but still we have the same kind of resistance mechanism. So bypass mechanism, small cell transformation, EMT, phenotypic plasticity, and mutation on the target. So basically, what we see that we switch a little bit the proportion of resistance, but still we have some resistant mechanism arising. So, do you think that monotherapy can overcome resistance?
No.
So now the second part is combining with trametinib. Okay. What can you say about this? Is there any clinical trial about this?
I'm not sure. I haven't seen it, but they say that ERK1 and 2 can be reactivated upon the osimertinib treatment, and so that's why they have the trametinib into this experiment. But I'm not sure they. I don't know.
Yeah, there is one, but there is no results yet. But the publication started with the rationale that there is a clinical trial because we know that there is a reactivation. It's true for all targeted therapies. The first response is downregulating this pathway, but after 48 hours, we have a rebound of the pathway. But now they are in the third line, so the third combination in two pills that have not been approved, and they propose a third one. So, like a bit. Okay. So you had the graph on the, I don't remember where. When you compare the ERK activation and YAP activation, and you say that these are two different pathways of survival. Next one. Next. Yes, this one. Okay, so where did you find that?
I found that in this part.
Okay, in the application. Yes. What do you believe with this kind of result you have explained? and this graph. Do you agree with that when they explain?
I think the gap activation is linked to previous stages of the tumors in the resistance. It's a consequence of the reactivation of ERK1/2 and all the mechanisms.
But it shows that gap activation was due to osimertinib and proleptinib pathways in activation. So how can they not link both pathways?
Using only osimertinib, they could see if gap
Osimertinib and gap.
Yeah.
So the conclusion is that gap can be another pathway driving survival, but all the articles is gap activation upon combination treatment with osimertinib. So I kind of mixing two concepts here. And when we go back to the previous one, you can see that osimertinib, not this one, yeah, this one, no, up there, yeah. Okay, so because there are lots of data here, but when you see osimertinib alone and apoptosis, and you compare with osimertinib and the inhibitor of gap, you see that this is an intermediate activation of cell death. And this is only when you have recombination that is a full activation of cell death. So it looks like you need the three to have the full survival, not just one and the other. And did you read something about the ZAF 939?
It's a Tonkuras inhibitor that is inhibiting the Wnt inhibition of APC.
So is it the YAP inhibitor?
No.
No.
It's in
No. So this is a kind of paper that has lots of different techniques, and it looks great, but there are lots of different things that make you think that maybe it's not really using in this kind of therapy, and the inhibition of YAP can be explaining part of the resistance, but they do not really demonstrate entirely the effect of YAP. And it's exactly the same for the EMT factors. They just evaluate at baseline, but not on treatment. You can see the expression of the slug, the snail, it's on at baseline, but not under osimertinib treatment. The relationship between EMF and EMT or slug, it's not clear, basically. So you can have some criticism about a paper, even though it's a very nice paper, very good paper. Other questions? So would you give this combination to patients? What are you saying?
There isn't a clinical trial on this based on the result of this paper. Like with me, we don't.
No, there is no. You have to learn first in preclinical models, toxicity, because we know that just inhibiting ERK is complicated. You have to treatment in melanoma patients with low doses. It's a bit better than monotherapy, but still we have some toxicity. So third combination, like we have to take care about toxicity.
They say WOOF has a lower risk of toxicity in the article, but nothing serious, I think.
And also, if it works, as I said, they could use it at in the beginning and then remove the third therapy.
Okay. So now YAP is an important partner of the kind of therapy. We know now that YAP is inducing resistance or preventing apoptosis in different targeted therapies, not just this one. And it can be used for monotherapy as osimertinib or blatinib or lectinib therapies. But we don't have an equity inhibitor yet. But it's YAP cell inhibitors, but that's not developed at this stage.
Yeah, maybe they could study MYF a bit more too, because it inhibits TED and not YAP, so it's maybe much specific.
Yeah. Online, do you have questions? Comments? Something? No? Okay, thank you. Comment vous l'avez remis du coup le portail de temps
Alors, c'est bien.
Okay. So I meant like a general overview of what we have seen with development of this inhibitor and what example of what we can do in the lab. If sometime someday you are interested in working on this kind of therapies, so you don't have to study lung cancer. You can. There is a lot of different cancer that receive this kind of targeted therapy. So we have melanoma, we have colorectal cancer, and saying more. We have new inhibitors, new targets. So this is a very open field. So very brief overview of. Okay, so now let's switch that. Okay, so this is kind of overview of the different therapy we have. We have surgery, radiotherapy, chemotherapy. So this is cumulative, okay? So this is not one replacing the other one. Yes, we have all these kind of therapies that can be mixed and combined, okay? Usually for low grade, we can have surgery, can have mixed radiotherapy and chemotherapy. And now we have two revolutions, the targeted therapy and the immunotherapy, okay? So we have spoken about targeted therapy. You have heard about immunotherapy. Okay, so targeted therapy for EGFR lung cancer. We have much more targeted now. We can have also for breast cancer, for prostate cancer. We can have this kind of therapy. And immunotherapy usually is for PD-1 or PD-L1 expressing tumors. Okay, so did you have a lecture on this? Immunotherapy. Okay, so you know that one of the best marker, which is not perfect, but it's the only one we have at that time, is expression of PD-1 or PD-L1 that can predict efficiency of immunotherapy. Okay. So as you can see, these are classified as a global approach. So we don't have any target. We just want to kill tumor cells, wherever they are, or removing, or just targeting proliferating cells. And these two strategies are on target. We have identified one target, and we want to kill the cell by targeting this specific target. But there is a difference between those. This is personalized medicine. Okay, so we have to look at the patient's characteristic. PD-1 and PD-L1 expression, it's independently on the patient. We have or we don't have. But here we have to find the oncogene, the driver oncogene responsible for cell proliferation. Okay, so this is one of the differences. We have I don't, but clinicians have tried to combine both, but it's very complicated to date. It's very toxic. Okay, so the combination of both targeted therapy, whatever the targeted therapy is, combined to immunotherapy, is toxic. Okay, so we cannot give both to patients at the same time. And patients that have this kind of oncogenic addiction that is not really oncogenic addiction, but still there is EGFR mutation, ALK mutation, ROS mutation. This is more oncogenic addiction that do not respond to immunotherapy alone. Okay, so the best solution for these patients is still targeted therapy. Okay, so yeah, the idea is to prolong survival and to decrease side effects. So why do they work? Because at the beginning, there is no evidence that targeted therapy could work. Okay, so as I told you before, this is kind of what we knew about cancer progression. We have initiation, promotion, and progression. And we thought that this was due to activation of an oncogene, but not alone. We have also inhibition of the tumor suppression and altered gene expression and epigenetic and metabolic changes. Okay, so this is kind of old concept because now we know with the mice model we have seen at the beginning that oncogene activation can be enough to promote cell proliferation. But now it's more complicated than this because there is different studies, and one big study that was published last year about pollution, air pollution, that was responsible for tumor promotion, but not for oncogenic mutation. Okay, so what the people found in the UK, in England, a big group with Charles Swanton that published one Nature per day, incredible. What they found on thousands of people is that half of the people, so here we cut the room in two, half of the people have an oncogenic addiction in healthy lung. Okay, we can have EGFR mutation, KRAS mutation, ALK mutation. Okay, but it's not enough to promote proliferation. We have to have promotion. Promotion can be due to pollution, can be due to tobacco consuming, to a lot of radon exposure, or a lot of things. But still, we can switch the concept of oncogene addiction and promotion of tumor just with one oncogenic driver. Okay, there are a lot of different events governing tumor progression. But we have a response. Okay, so why do you have a response? Because at the beginning, as I told you, we can have some mutation on tumor cell. This is probably not enough to create and promote progression, but still it may have some help. Okay, they can help to have tumor progression. And why that? If you can see there is an aggregation or something that promotes progression, okay, the cell can proliferate and become tumor. Okay, so this is a long process that can evade immune system and so on. But the important thing is that this occurs at the very beginning of the disease. So all the cells do have the mutation. Okay, and you have questions? You can interrupt if you have questions. And what we see, so this is something I represent because you will understand what we discovered this year. Once the tumor progress, there is a differentiation that lose characteristic of normal cell. Okay, so if we begin with a normal epithelial cell, alveolar type 2, alveolar type 1 that progress toward cancer, you lose the characteristics, the ID card. Okay, so you don't recognize this cell. You take a cell, there is no marker of epithelial cell. This is kind of complicated to treat them. Okay, and so why targeted therapy works? We don't know. Well, mutation. Kind of. I told you that we have to have a genetic events, mutation, a deletion, and amplification. Okay, we have the oncogenic driver that promote proliferation. This is also something. All the three presentations are exactly the same, and we all present the same. We all present this pathway, so it can be EGFR, ALK, KRAS, other oncogenic driver, and mixed proliferation and survival. Okay, we have no explanation why we put all together. We have the AKT, ARC, STAT3, all this pathway, And all these pathways promote survival and proliferation, mixed. But in the reality today, as I told you, there is no explanation why we mix proliferation and survival. Both can be separated, and there is no explanation why targeted therapy kills the cell. What they can do is to stop proliferation, but why they do kill cells, they do, but why they do kill cells, we still don't know. So it's like, it's okay, it's good, they're working, but we don't know why they're killing cells. Okay, that's stopping proliferation, that's clear, but why some cells are dying, we don't know. Okay, so targeted therapy causes cell death. And why it's working? Because all the cells do have the oncogenic driver. So when we treat, all the cells do respond. They may die, surprising that they die, or they just may stop proliferating, but it affects all the cells in the tumor. So that's the beginning of the story. What I told you is that there is some paper that do show that there is an overexpression of EGFR. That's why we developed allotinib and gefitinib. But in the first attempt to see whether they were working or not, as you can see, there is no effect at all. So fail, completely fail. No effect on overall survival or not effect on PFS. Except for this subset of patients, we saw that they do have some kind of response. And in 2004, there are two revelations. So the first one published in Nature, I think, and the second one in Science. So it was Science and New England. And as you can see, it was exactly the same week. So both groups identified EGFR mutation in patients that did respond to this kind of treatment. Okay, so now we have a biomarker to select patients that do have this kind of mutation. We know that there are two groups of mutation on EGFR. There are different ones with, for example, exon 20 that are more difficult to treat, but now we have treatment specific for EGFR exon 20 mutants. But still, it was the first revelation of this kind of effectiveness in patients that have mutation. Okay, so EGFR inhibitor only works in EGFR mutant patients. So if you are clinicians, do remember this, because there are still clinicians that treat patients with EGFR tyrosine kinase inhibitor for patients that have KRAS mutation. So it's not completely nonsense. Okay, so I don't go back to this, just say that allotinib is better than chemotherapy. We have better response. You can see here, so the curve is the maximum response. But again, you see that maximum response is okay for this patient here. So the reduction, tumor reduction is good, and the maximum response. But there are lots of patients that do response, but just have reduction of tumor and not complete killing. So when you have a drug that targets all the cells, you can expect that all the cells will die, but it's not the case. So the cells do respond, they just stop growing, but then they acquire resistance mechanisms. So this is why the curve is not dropping at 100% here. Okay, so now this is some explanation of what we knew before 2004. So we have just KRAS mutation. So KRAS, you may have heard about KRAS oncogene, which is the most mutant oncogenic driver in all the cancer, not just lung cancer, it's cancer and pancreatic cancer, and so on. But it was considered undruggable until very recently. We have now EGFR mutants, and now this is like a kind of panel we can have with targeting agents, can target ALK, EGFR, ROS, BRAF. We have a subset of patients with KRAS mutation that can be treated, and this is ongoing trial. So now we can treat also patients with different KRAS mutations, not just G12C mutations. So we can have lots of different targeted therapy available for patients, and we can find targeted therapy for more than 60% of patients now. So we have best response and best overall survival. So what the problem, as we can see, with erlotinib. So this is also a cartoon that I always show. We have response, but we have development of resistance. I told before, there are 3 different groups: on-target alteration, bypass pathway mechanism, so activation of another pathway that do promote cell survival and cell proliferation, or cell plasticity. Now we have osimertinib, 10 years later, and still we have some alteration. We have new compound that target both mutation, but we can imagine that it will be the same. So for clinician, it's quite okay. We prolong cell survival, we have better care of patient, but for researcher, this is not enough. In researcher, we want to kill all the cells. So we try to understand what's happening in the beginning of the resistance. This is what we have evolved in 20 years. So it's 6 months. It's okay, but it's not enough. Okay. So the 2 hypotheses of why there are resistance. Okay. So we know that some cell responds and develop resistance. The question is how. Okay, and this is what we do in the lab. We're trying to understand how a cell can become resistant. Okay? There are lots of models that can be implied. There are lots of studies that have been performed to study resistance. You can take a resistant cell, you can promote resistance in the lab. You can treat your cell with erlotinib or osimertinib and just wait. And sometimes you have resistant clones that emerge. You can compare both. Okay, you have this. Okay, you have a cartoon of what we see at resistance. What we can see is that there are a lot of resistance, different resistance among patients and within a tumor. So if we wait until resistance, it's very complicated to treat patients. We can treat a subset of patients. For example, if we have MET amplification at resistance, we can give MET targeted therapy. So targeted therapies that target MET, but patient always develop resistance. Okay. So this was the first idea, is that there were a pre-existing resistant clone in the cell. Okay, so this is easily understandable. So you have a pre-existing resistant clone that is selected with the Darwinian selection on treatment, and the cells are just evolving because they are already resistant. Okay, we now know that this can be true, but it's not the main case. We believe that there is more an adaptation of the tumor. Okay, so lots of cells are dying. We don't know why, but they are dying. And some cells just stop proliferating. And meanwhile, some of these cells can acquire resistance. Okay, so now we have to look at this dormant state. So in the last publication, we have a dormant state with the combination treatment with osimertinib and trametinib. We can observe that with mono treatment. Can have some models that are dormant, but still some cells are waking up somehow. So this is what we learned in the lab. So what we did is to select some cells aligned with the EGFR mutation. We added lots of different models. Okay, and we just treated the cell with erlotinib or osimertinib. Okay, the EGFR targeted therapy. But to make sure that there were no previous resistance mechanism, what we did is to subclone and to pick the cells that were sensitive. Okay, so now we are sure that in the bulk population there is no pre-existing resistant mutation. So the only way to survive is to have an adaptive selection. Okay, and then to follow the evolution on treatment, what we did is to transduce the cell with the Fuji system. So the Fuji system is the best tool I have ever seen. Now I use it in all my cells because we can monitor the cell cycle dynamics in real time. So under treatment, you can see whether a cell is proliferating or not proliferating. So how it works? So in G1, they are red. Okay, and if they go to SG2, they become green. Okay, it's easy. So in G1, you can see there is a copy of DNA, and then in SG2 there are duplicating DNA and then doing mitosis. Okay, and this is how cell cycle works, and this is how cell proliferates. Okay, so doing this, what we can see on treatment, this kind of movie. So you have the cell that proliferate, and when you treat, they go all in G1. So they stop proliferating. Okay, this is working, but they are not dying. They're just here. And some cell can escape. You can see the green cell are escaping. Yes. Okay. A lot of just here, they are not dying. They're not dying. Okay, but some can wake up. Okay, and when they wake up, they can divide, and then they can form a resistant tumor. So this is like a neogenesis of a resistant tumor. So we can monitor that in the lab. And we can see this is kind of response. Okay, you have decrease and then relapse. But if you look at the cell cycle, you see that all the cells are stopping in G1 and some cells are escaping. Okay, in the green line. So what does that mean? That means that cells are waking up during the response. Okay, when the bulk population is dying, some cells can escape. Okay, so we can monitor that in different targeted therapy, in KRAS, in ALK, in BRAF, in EGFR, it's all the same. You have first G1 stop and then development of resistance. So now we go back to the ID of the cell. We can select the green cell and the red cell to see whether they can have some mechanistic differences and to explain why a dormant cell is dormant and why they are surviving, and why a green cell is escaping and proliferating. So just focused on the G1, so the cell is arrested. Okay, so you block the EGFR receptor. Okay, the cell is not evolving, it's just like here, it's surviving, it's not proliferating. And when we look at the characteristic, the cell look like normal cell. Well, marker again of pseudo-normal cell. Okay, these are markers of alveolar type 1 cells. Ager, SFTPV. So these are markers of normal cells that have been lost during tumor progression, but they are reacquired. But this is very transient. This is the first response. But then cells are evolving from this phenotype to proliferation. So now we can understand why some cells can differentiate to small cells, because become normal again, but they can switch to another kind of normal cell, can switch to small cell, neuroendocrine cell to give rise to small cell lung cancer, but still keeping the genetic of the primary tumor. Okay. So we identify the new identity of this cell. We cross different models on this, and we define the doctorant signature. So the cell that are tolerant but not dying and giving rise to resistant cells. And we search for a specific target, and we found just one. So this is the story we just published. So we identify farnesyl transferase inhibitor. So this is a group of drugs that have been developed a long time ago. They are not really efficient alone, but when we combine to EGFR targeted therapy, as you can see in red here, we have complete response in this model, and we can see that it's true for all the models. In EGFR, KRAS, ALK, BRAF. When we wait for relapse, we have relapse in all the models. So this is a targeted therapy and relapse. Okay, we have relapse, but if we perform combination treatment, we don't have relapse. So it's more or less the same that the gap story. Okay, so we have now PDX model for that. Okay, so you have better response with targeted therapy and TP-farine, which is a farnesyl transferase inhibitor. And we have the same thing in EGFR exon 20. So this was kind of fun because we didn't expect to have a good response in exon 20. And we have also good response in KRAS. So these are two models of KRAS. We have better response and control disease. Okay. And now we have a clinical trial ongoing in United States. So just to make sure that the combination is not toxic, and it should reach to phase 2 and 3 in early 2025 here in Toulouse and in other groups in Europe. Okay, so this is global response with all the models. We can see that in addition, we have better response with the competition. Okay, so yeah, this is the resume the finding. So, okay, so we have to focus on this particular phenotype to, as I say always, it's much better to prevent resistance than to treat resistance because treating resistance is very, very complicated. Okay, so if you want to see, there is an online article on this. You have question, comments, something? No? Yes.
What is the toxicities of this treatment? You have any idea?
In the combination, we are evaluating. There is a first clinical trial in 2000 with erlotinib. We were lucky because in 2000, erlotinib, as I told you, it was used for any patient. Okay, patient that didn't have EGFR mutation because we didn't know that EGFR mutation existed at that time in 2000. And there is a trial with the combination of erlotinib and tipifarnib, just evaluating toxicity, and it looks like it's okay. There is no more toxicity than the combination of both. So we believe that the combination will be okay for patients, but this is ongoing trial now. Well, with patient with so it's not EGFR at that time. We have started with KRAS mutation, okay, because the relapse is earlier. So we try to focus on patients that relapse earlier to evaluate the drug. But if it works, it will switch to EGFR mutant patient and osimertinib. Yeah.
Do you think we will obtain the best remission rate for these patients? For instance, do you think with this combination we will kill all the cells? And finally, the best idea would be to initiate the combination the first line, or rather than initiate the combination after relapse.
Yeah, we're trying both. We believe that the combination first line is better, more efficient, but we have some responses at relapse, but we don't know why. So we are evaluating the models that do respond after relapse, why they're responding after relapse. That's a strategy here was to start giving the treatment at the beginning to prevent the emergence of this particular phenotype. So at the front line, it's quite efficient. We will see in patients, but it can be efficient for some patients that relapse. Okay, so thank you all. More questions, you can write an email.
All right, so why this is not showing up? All right, so next step will be to show up the screen. Not sure. Something? Okay. Can you tell me if you see the slide online, please? I hope that's a yes. That's a yes. Good. All right. So, okay. So let's go because I have to speak English. There are people online for the Eurocare. So it's a pleasure to be with you today. So the thing is, my name is Pierre Cordelier. I'm a researcher at INSERM, working in Cancer Research Center of Toulouse. And today I will share with you the work we're doing on using virus to treat tumors. So I've changed a little bit the title, but the content will be exactly the same. So it's changing scourge to cure. And before going into details in how it may work as a cancer therapy, I will drive you between the interactions of humans and virus along evolution. That's quite fascinating and interesting because I know it's late in the year, it's late in the day, there are some strikes in the trains. And so the idea is not to give a conventional lecture, but to have a discussion. So please interrupt me if you feel you need some more explanation or if I'm not correct or if I misunderstood something, okay? You should work because if not, I will send you back somewhere. Anyway, no, come on. It's always the same. Le truc en ligne, c'est sympa, mais jusqu'à ce que ça marche pas, en fait. Et j'ai pas de souris connectée sur le mur. Voilà. On va y arriver. Regarde si ça marche. Wow, c'est trop. Okay. So that's pretty interesting to drive during evolution and disease. And we learned a lot from the last 5 years. We've been dealing with a kind of virus. And we have to consider that by the time in antiquity and early century, viruses were not even visible. So it's more about speculation, tradition, and we know that there are powerful forces that shape human evolution. They evolve with us, and we evolve with them. You have to know that 30% of our genome is made of viral sequences, and some people are doing some phylogeny tree, to know who is where and who is coming from where, and they could recapitulate some migration based on pandemia during the old ages, let's say. That's quite interesting because if you go back to the history books, I was not exactly my piece of cake when I was a student, but anyway, you can understand how outbreaks just emerged and how they were managed by the population. And we had to be highly resilient. We had to adapt to the impact of viral threats. And at some point, we may benefit from this knowledge to treat cancer. That's really interesting because the earliest evidence of viral infection comes from mummies, with viral scars on mummies that are highly evocative of smallpox variole pustules, just like the monkeypox, but that's a human one. And there've been also some interesting discoveries of 15,000 years old viruses that emerged from a glacier who melted down. I was in Tibet, I think, something like that. Oh, by the way, I will share the slides with you, so for you to focus on what I'm trying to elaborate with. There are many historic plagues that have been reported, pox and measles in Mesopotamia and Chinese texts. So measles is rougeole, so it means some common virus infection. And there was a really early recognition of contagiousness. That's really interesting because the people were not even aware of something that was disseminating a disease that they thought about isolation practices. So we heard a lot about that a few years ago. So it comes from a long time ago. And the response at this point were prayers, not human sacrifice yet, but rituals, amulet as protection. Someone may think about what we heard during the COVID pandemia. Some people were very skeptical about how to handle a viral pandemic, and it's been there for a lot of time. If we go to the Middle Ages and pandemics, this is something that really imprinted the medieval times. When you have smallpox again, and other viral diseases, I was thinking about another one that's not top of my mind. that devastated Europe, Asia, and the Americas. How this could happen? Basically because we were the vectors. We were the one bringing a virus to another place. And you have the trade routes like the Silk Road. And there are, again, I will show you an illustration of a map showing how, because people were, exchanging stuff, going to China, they also spread some viruses, some plagues and everything. Urbanization, there was a time that people were regrouping together, and let's say that the hygiene was quite limited. No sewer, nothing. Everything was going to the streets. It's not the best way if you want to, avoid some contamination. And there was this, those viruses coming from old world, smallpox, again, to the Americas, causing massive depopulation. And maybe you've heard of that. Some Spanish conquistadors were giving some tissues and other stuff for the Indians to wear that were supposedly contaminated with smallpox to eradicate those populations. That's bioterrorism. And this is how you can find, smallpox is here in blue. And I think that's, yes, leprosy in red. How the roots, the people bringing those diseases from one side to the other of the world. And actually, I don't know if you've seen this documentary on Arte about the first days after the COVID-19 pandemic. And again, I know it's really hard to take the right decision at the time when you don't know if it's going to be a simple cold or a global pandemic. But the 3 days after the WHO found out that was going to be a pandemic were very, very important. And by this time, they did not close the airports. I'm not saying that they should have done that because you never know. It's easier when it's done. But one way of the virus to travel the world was us taking the planes, okay? But still, isolation was as early as the 14th century in Venice, in Italy. I don't remember the word in Italian, but that's kind of the Ace Island of the people being contaminated with viruses. And because, by this time, Venice was the largest port on the Mediterranean Sea. So you had to stay a little while in those buildings that are still there, actually, small islands, before getting to Venice to make sure that you were disease-free. And then came the birth of vaccination. And this picture summarizes everything. That's Edward Jenner with a cow. Why a cow? With a smallpox vaccine in the 18th century. Actually, this guy, Edward Jenner, I think he was a physician at some point. He observed that milkmaids, the one taking care of the cow, never got a smallpox because he thought that they were exposed to cowpox, which is another pox viruses that is pretty close to the smallpox that is infecting humans. The cowpox is infecting cattle, but not humans. And so that was the first exposure that made them immune to the virus that was life-threatening by this time. Then he thought about practicing on a baby from the farm who was visiting the cows, by the way. Interesting clinical trial. And then made those scarification using cowpox material, so live material on the virus. And we will see that by this time, there were no modern technologies to make recombinant viruses. And so this 8-year-old boy eventually was protected from smallpox. Basically, this guy pioneered immunology, and we can say that it saved millions of lives. And then, 19th and 20th century, the main advances is seeing is believing. So that was the first picture by electronic microscopy all these tobacco mosaic virus by those two Russian guys, Ivanovsky and Berezhny, in the late 19th century that identified this virus by filtration. That was almost the same time period of the Pasteur and the Pasteurians. So eventually you will pinpoint a pathogen that was spreading a disease. That was the first time, the first evidences that something was going wrong. And so vaccination went to another level with the polio vaccine in the 50s. Actually, there is a story behind that. The polio vaccine was contaminated with poliomavirus, SV40. I know maybe you know SV40 has been used to transform or immortalize normal cells with a large T antigen, because the vaccine they were using on cells that were contaminated with the virus. And then when came the campaigns for eradication of measles and rubella, and eventually in 1980, the World Health Organization declares that smallpox was eradicated, making the first humanities free of virus of one kind. Actually, do you think it's true that there is no more smallpox on Earth or not? Obviously, the answer is no. Why? Please? Sorry? Why? Smallpox? No. Rabbit pox? Yes. But you know, the smallpox, there is two vials. Now, one is kept in the US, the other one is kept in Russia. Because the population is not vaccinated anymore against smallpox, that will be the ultimate bioterrorist weapon. So it's not super. It can be scary, but there's still a vial of. We'll come back of science fiction and virus. But actually, there are pox viruses. You're right. There are pox viruses in the lab. Most of the people are working on other species that cannot infect humans. There was this example of a scientist, between quote, that made clear that you could put back together the sequence of a smallpox virus by ordering primers and then ligation, transformation, making virus. So I don't know exactly where is this guy now. The thing is, we have this very funny thing happening a few months ago. I'm working with someone, I will show you some pictures, who's dealing with different viruses, and he has to work with pox virus, but not smallpox, not the one that are infecting humans. At some point, he ordered some primers, just like anyone can do, and then 5 minutes after, he had a call from the army, because the sequence he ordered was blasted automatically by the provider, and then came out positive for a potential hit for smallpox DNA. So there are many things going on when you place an order. The army is very, very careful about what's going on, and bioterrorism is something that is still can be acted, not in France, of course. All right. So what will be the next challenges? There are outbreaks, emerging outbreaks, just like COVID-19. Some re-emerging viral threats, malaria, meningitis, dengue, gastroenteritis. So that will be the next level for the years to come. What we learned for that is we have to remember in the past what were the previous pandemia, HIV, 39 million of deaths. It's a lot of people. It's still rampant here, actually. I was surprised. I had to do a blood test at the clinic, and I have this advertisement of two young people and asking for screening for HIV because it's been so common now to think that HIV can be cured and treated that people get less serious about what they can do to prevent contamination. So it's back again. So careful. SARS, that's a young brother of the SARS-CoV-2. H1N1, the famous avian flu, Zika, that's coming from mosquitoes, and COVID-19, of course, in 2019, easy to remember. What is driving outbreaks? Urbanization, climate change, because some species are proliferating, deforestation, global travel. Why deforestation? Because we are getting into contact with species that we are not supposed to. I'm not talking about the poor pangolin who got all the COVID-19 story on his shoulder. And global travel, because you can spread the disease very, very fast. So it's like the 12 Monkeys army also. Many science fiction about that. That's pretty cool because now we, how can we do better? We had this global case study about COVID-19 that showed that rapid vaccine development and global response systems are mandatory for that. I would like to remind you that RNA was known before COVID-19, even if my own family teach me what was RNA. They never did biology anyway, but it's okay. Personalized vaccination was there before. It was not for a virus, it was there for cancer. Angur Sahoul was working on melanoma. And delivery of mRNA was closing to an end. And what was quite remarkable is that those three main pieces in the puzzle were at the time, you're putting together, putting all the money on that, and there was a global response. It's not, again, we created a virus because we want someone to be vaccinated. Okay. Once again. All right, so what will be the next viral challenge? How to do that in research, and then I will switch to the main topic of the presentation. To be predictive, now people are anticipating mutations by genetic sequencing of the viruses, but also modeling, artificial life science. The people in the IRIT, the Computer Science Center of Research in Toulouse, are very good at that. Going for universal vaccines with conserved viral elements. That's one way to be, just like, when we have those flu shots, we know that from the east, the flu is coming from the east. The vaccine is adapted when the flu is hitting the west population, just like in France. AI, machine learning for outbreak tracking and response. It's very important when we want to know whether or not we have to close all the airports or everything to prevent from contamination and dissemination. And of course, I don't want to go back to this picture with a mask on Earth. So global collaboration remains critical. It's a hallmark of science. So basically, that's when you say virus, when you say human, that's a co-evolution story. We can learn from both sides. It's a story of survival, adaptation, and innovation from both sides, actually. The virus, which is not even being considered as a living agent, it's considered as a parasite. So in definition, it's not living, but I'm not a biologist, I'm a cancer scientist. We have to increase the need for vigilance and science-based approaches. I mean, it's very important if you want to make sure that the population is following. And the thing is, if we go back to the viral cycle, there's something that is very interesting. So you have something that is entering a cell. So that's a virus that is attaching, that is entering, because the virus cannot do itself, and can do nothing by itself. It's not even considered as living, as we discussed. It has to hijack the cell with a machinery for making DNA, proteins, lipids, sugars. And then what is quite interesting is that by the end, the virus is released. And by release, I mean the cell is exploding because of viral load. And that will be very interesting if you want a virus to infect specifically or replicate specifically in a cancer cell that you want to explode, basically. And the beauty of it is that the virus can infect other cells that share the same phenotype. That's the idea behind using viruses against cancer cells. And it's not a new idea. Actually, that's more bacteria than virus here, but That's Coley's remedy. I was in the early 20th century in New York. The guy figured out that people that were suffering bacterial infection, their tumors, from time to time, they were regressing. They were disappearing. And so what the guy did was to take a mix of this bacterial whatever and injected that to other patients with cancer. And he had some success. And we see that then they get more brave in the clinical trial they want to do. But there are some examples that are quite very interesting if you go back to the books. Here, that's a 4-year-old boy with leukemia. So leukemia, blood disease, you see the numbers here are super high. And then the guy is developed varicella. Varicella is caused by a virus, by the way. And during the time the kid has varicella, the counts are very, very, very low. So the virus and the cancer cells are not doing well together. But then varicella is treated with ACTH and the virus is going back with cortisone and everything. Bad call from the physician. Here, that's another story, another famous story. And that's really interesting because from the start, I want to talk about oncolytic virus and not oncovirus. You know the difference. A virus can induce tumors. We talk about SV40. Do you know another one that can make tumors? Ladies? I'm getting that. And boys also. Thank you. Papillomavirus can transform cells. And then there is another, that's an oncovirus, making tumors. I'm not very happy with oncovirus. This one is another oncovirus, it's Epstein-Barr virus. It can cause it, I don't know, he or she, it can cause Burkitt lymphoma. This kid has Burkitt lymphoma, and you can see that because that's bones all over the place. That's the sinus that are filled with leukemic cells. And so the counts here again, they are very high. This kid got a shot against smallpox. That was the time smallpox was still given to kids in the 70s. And then smallpox, with again the tumors, they are not doing well. The tumor is not very happy with the live virus because at this time, the smallpox vaccine was attenuated virus, meaning that there were still some probably immune response against the virus or even replication that will hit the tumor cells. And so the kid, after vaccination, was free of tumors. So how does it work? And going back to science fiction and everything, I'm pretty sure that you've seen stuff dealing with oncolytic viruses. Not maybe the proper way, I would like it, but anyway. From time to time on W9 or GA or whatever, from time to time you have this movie, 28 Days Later. This is coming from a book, an English book. This is pretty scary. This one is funny. That's the same story. I Am a Legend. And I mean, I don't know if you remember, this one was Will Smith. I'm going to say the word again. Sorry. The first minutes of the movie is an oncologist. That's a woman. I don't remember her name. Anyway, she's on CNN. Someone is asking what she's doing. She's been developing a measles virus, so virus de la rougeole, against cancer. That's proper. I mean, you can do it, and we'll see an example later. To treat patients with cancer. And the journalist is asking, how many people have you treated? 10,132. And how many are cured of cancer? 10,132. Still, there is a little adverse event because the virus is killing everyone except a few people, including Will Smith, and guys that just want to eat you down. Those zombies that are, they live during the night and they want. So it's not super interesting. I mean, it's not, for me, it's not very good if a reviewer of a paper of a grant just saw the movie the day before is looking at my work. So So this is not good sign for me. But I mean, again, science fiction, a pretty cool movie. It's very funny. I mean, except when the dog is. Oh, sorry, I'm spoiling this stuff. But the thing is, it's very funny. But there is some facts behind this sci-fi movie. And then we talk about clinical trials. So remember the guy, bacteria, not doing well with tumors. Let's do that with viruses. Okay, so I will not comment everything, but there's something, a question I will ask you at the end. But let's start with hepatitis B. The idea was to use virus, hepatitis B, to treat people with Hodgkin disease. So this is again a blood cancer. So they were using human serum patients with hepatitis B or cell extracts from the patients to infect. So of course, there was a really nice positive control. 14 out of 22 of people receiving that got hepatitis. That's a live virus. It's just crazy. With clinical improvement, tumor regression, one death. Okay? And then he went on and on and on. I will not go into details, but you will see that everything was, sampled from patients, even chicken, saliva, supernatants. There is something very important in the 70s, except some pretty cool music. There were something that was invented and democratized, I don't know if it works, in the lab in the 70s. You have been trained to that. If you're dealing with cells, what will be that? In the 70s. Why were they sampling things on patients? Don't worry. What should you do now, the vaccine? You know how vaccines are made? Or virus are made? On what? That's a parasite. So it needs a host. Okay? What kind of host? Not a patient. What will you do to grow a virus? You will infect what? Recombinant? That's a step way after. First step, you want to infect what? Very easy. The cell. But there was no cell culture by the early 70s. So they had to sample patients. Now with cell culture, you do recombinant DNA, you do whatever you want. You infect, most of the time it's chicken embryos to make virus, and so on. Chicken eggs to make vaccines. That's why some people allergic to albumin cannot be vaccinated. So by the time they had to sample the virus where it was, on patients. That's going to be scary. Anyway. So how does it work? I mean, how can the virus can kill a cancer cell? So basically, I think, might be wrong, I think that viruses can infect all cells. But then something happens. If you go for a normal cell, you will have an infection, the virus will enter. But the thing is, maybe the cell will die, but there is something here which is super important, that's biosensing. Because it's not usual to have free DNA or RNA that can be the genome of the virus within our cytoplasm. There are defenses, CGAS, STING, RIG, TLRs that are sensing those extranuclear DNA or RNA and then shut down translation in the cell. So that's not a direct answer to the virus infection. That's a countermeasure about something foreign getting into our cells. And so there are two solutions. Whether the virus will not replicate, but if it still can replicate, okay, one cell will die, and that's it, and the population will be saved. Maybe. That's the extreme situation. Most of the time, the virus cannot replicate, it's washed away, that's viral clearance, and move on. Nothing to see. For a cancer cell, that's way different because the virus can enter the cell. So it might be some receptor. Most of the time, it's not common, but can be. It can be that cancer cells are engulfing a lot of things, could be virus on top of it, because they need nutrients. And then the virus can replicate. Why that? Because the viral sensing is gone in cancer cell. That's a Troy horse story. You don't have those interferon, you don't have those TNF answer, because it's not good for a cancer to progress. An interferon response will be immunoactive against a tumor. So actually, that's in pancreatic cancer. They've seen that if you have MYC and RAS, that are two very strong oncogenes, they are silencing the response of interferon to maintain a phenotype that is immunosuppressive. So it's good for us, not for the tumor. That's good for the tumor to be infected by a virus because there is no more protection. That's pretty cool, actually. Achilles heel or something like that. And then, of course, the virus is a parasite. It's called an alloparasite, meaning that it's obligatory. The bacteria can replicate. The virus will not, without a host. And for replicating, it needs fuel, it needs energy. And this is a scheme of the virus that are benefiting from either OX4 or glycosis in a cell. And you know that in a cancer cell, the metabolism is highly altered. So no interferon, high metabolic. It's a perfect combination for the virus to thrive, disseminate, and then to kill the cells. And there is a icing on the cake. That's at the level of cells, cancer cells. If you put that into a host with an immunocompetent system, the infection, the work of the virus, let's say, will be sent as an infection, meaning that the cancer cells will unclog themselves. They will produce alarmins, DAMs, PAMs, cytokines. And so that will be a nice opportunity for immune cells to be recruited to the site of infection, that will be the site of the tumor. Because most of the time, the tumors are immune excluded. And so if you bring back in the battle the immune system, can act against the tumor cells, you can combine with immunotherapies, and in theory, at least in theory, you can hope for eradication of tumor metastasis. And that's no surprise that most of the clinical trial to date, the modern one, not the one with adenovirus sample from hepatitis B virus sample from someone that is sick from hepatitis, are given with immune checkpoint inhibitors. And then there is something really interesting. You have two sides of the coin. Of course, you hope for the lysis will open up kill cells for antigen presentation, just like the holy grail neoantigen that will be recognized by the adaptive immune response to eradicate all the cells that share the same neoantigens. But this is you cannot compare with the power of a viral antigen. You will have a response against the virus. And more, and we are some of them, and I will show you some evidence, that the immune system, the immune response against the virus can benefit to an antitumoral response. We'll see that. Antigen spreading or cytokines that are produced. How does it work? That's moving, believe me. That's an infected cell. You see the nucleus, you see virosomes. This is viral DNA that is showing up. So you can track the virus. Here, this is one of those viruses, one pox, not smallpox, but rabbit pox. Don't ask me. That is replicating outside of the cell and then produce as variants and then killing the cell. Another nice example, this is pancreatic cancer spheroids. So the virus will show up, the infected cells will show up in green. And so you see how it works. Quite fast, coming from the outside to the inside, exposing everything. Good job. Oops, sorry. Another video in 2D. You see cells getting infected in red, orange, I think red, yeah. Virus is spreading, killing the cells, killing, spreading, killing, spreading. And this is something very funny we found out. Here you can see virions or groups of virions. It is too small. Here the virions are something like 200 nanometers, so you cannot see individual virions. So what we can see are a group of virions. I don't know if you're aware of that, but in case of emergency, a dying cell, especially a cancer cell, will transfer some material, will transfer some energy, transfer some mitochondria, because doing those active projection, it's pretty cool. That is, the virus is hijacking those actin protection to infect another cell. So there are many ways for a virus to spread and disseminate into tumors. All right, so they can come in different sizes and flavors. We know a lot about our own genome based on the study of the viral genomes and the molecular biology with IRES, those internal ribosome entry site that are coming from, our understanding is coming from viruses. They can be single strand RNA, double strand DNA, whatever anything you call. They can be naked, between brackets. So there is a capsid here that is protecting the genetic material. It can be either DNA or RNA with, let's say, a shell, a proteic shell, with some surface proteins for infection. We call that tropism. Tropos is lieu in Greek. And so this is how the virus will infect specifically one type of cell. And you have more fancy viruses that can have an envelope. So same capsid, same genetic material, protection, envelope, more surface protein, sorry. So if you have to guess, what will be the most robust virus? The one on the left or the one on the right? Left. You said left, yeah. You know why? Because envelope is a frailty. So envelope is lipids, so the virus is more frail and it's less robust. So why giving an envelope? Probably again a host parasite evolution. It's stealing the phospholipids from our own membrane. Bad guy. Those size really matter. Probably. Because if we look at the spectra of the viruses, you can have those tiny parvoviruses, 20 nanometers, more like this one, and the big, nice pox viruses, 250 nanometer. So, and in between everything, herpes, measles, adenovirus, rotavirus, all virus cannot be oncolytic, but to be oncolytic, you have to be a virus. That's all. And I mean, you can imagine that a pox virus will not have the same needs than a parvovirus to infect the cell. Not the same route, not the same need for endogenous proteins. For instance, the pox virus was the one I was showing you replicating outside the nucleus because it's encoding for everything. Just need amino acids, nucleic acids, and lipids, and that's it. Parvovirus got 4 proteins, with only 1 or 2 doing stuff. So it has to hijack a lot of things from the cell. And that's really interesting because more than studying a tumor or a virus, my virus is better than yours, blah, 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 blah. It's more about what will need a virus to replicate, what will give a tumor to replicate, cancer cell to replicate, to have a matching, virus against a profile of the cell. And that's where we're going for precision, okay? Not my virus is better than yours. I don't care. We've been using 3 different viruses from those 6 in the lab because we think that different phenotypes of cancer cells might be more suitable to be killed by those viruses. These are multimodal therapies. Why for? Because they can induce cancer cell lysis. It's not a magic bullet. It has limitations for sure. But it's pretty interesting because you can induce immunogenic cell death that will engage immune cells. Looks like everything that is not normal will get infected. We know you heard about CAF, probably, those fibroblasts associated with cancer-associated fibroblasts that are different, that are not only supporting physically tissues, but also supporting, I would say, by secretion or protecting the tumors, the tumor growth. And also those, I That's not good. Also, those endothelial cells that are not well organized, looks like when the cell is not normal, kind of activated, it can be infected by a virus. Probably, again, because all those TNF, interferon, antiviral response are long gone. And then, of course, collaboration with the immune system. And people have tried to combine virus with some therapies that are used on patients. Here, I may have a question. I have a question, actually. If you plan to use chemotherapy with a virus, would it be a good idea? Yes is a good answer. No is a good answer. Who thinks yes? So you are all against the combination of chemotherapy and virus. So who guess what will be the advantage of combining chemotherapy and virus? Except that if you want to go for clinical trial, you have to adjust to the drug that is already used for the patients. Don't be shy, come on. Answer in French if you want. I can understand French. Could be. Because different mode of action. Okay, that's one answer.
It will give the virus more opportunities to replicate because it's the person that which fight virus normally for the standard chemotherapeutics.
Replication and chemotherapy and virus. There is something liaison dangereuse here. No, liaison dangereuse is you said 3 words that should not work together.
Okay.
That's okay. That's might be a limitation. Virus, chemotherapy, so that's what I've said. And you said replication. You know, chemotherapy is what they are doing. You know the mode of action of chemotherapies most of the time? What is the target of chemotherapy? DNA. Any DNA. So it could also blunt viral replication. You know what I mean? You're right when you're saying that's a combination of mode of action. That can be right because something can resist to chemotherapy but not to virus infection and vice versa. But on the other side, you are using an agent that is inhibiting replication regardless of the DNA. So you have to make sure that, it's a jigsaw a little bit. You have to make sure that you think about the sequence of events. Chemotherapy first, then virus, vice versa. Let's try. And actually, what we've seen is that if we use the chemotherapy that is targeting DNA elongation before the virus, that will not work well because the virus will be poor. But if we do the other way around, it might be better. Priming for chemosensitization. So that's why you need to think about before thinking, I will do that and that. Obviously, no. Think about the mode of action. I'm kind of mode of action driven. Sorry. So thank you for your input. And then, of course, you can use those viruses, not the tiny parvovirus, the one with 5 kb of genome. You will not fit anything in that. But the myxoma, the herpes virus, they have something like 150 kilobase genome. So you can remove stuff, virulence factors, and add something to stimulate the immune system. We'll see an example. But then, for sure, and to be honest, the prime of the oncolytic virus came after immune checkpoint inhibitors hit the clinical trials with the beautiful results from PD-1, PD-L1, CTLA-4, and so on. Because those viruses were considered as immunostimulatory molecules. All right, what is the current status of oncolytic virus in clinical trials? That's real clinical trials, not the one that you're injecting, or the one giving zombies at the end. More than 1,500 patients have been treated, no serious adverse events. Sometimes when you're treating someone with a vaccine virus, it's doing something that the vaccine knows how to do. Those jobs. on your skin. That's a side effect, but that's because the virus is doing something. Okay? But then there is a strong attrition, starting with 60 to 3 approved viruses. That's always the case with innovation, but you need 1 or 2 to hit the approval by the FDA and the EMA, and then others should come. So there are you dead? No, not yet. There are 5 viruses. If you look into reviews that got accreditation, meaning that they give all the results, they give some positive results in phase 2, phase 3, and then they were granted by the FDA, that's the US Food and Drug Administration, EMA, which is European Medical Agency, and so it can be used in patients. Actually, it's wrong, because there are only 2. The one with the TVEC, been approved in Europe, USA, and the last one is adenovirus, Noda whatever, in 2022. The other one, the one in Japan, has not the FDA or EMA approval. Now being experimental in Great Britain. That's pretty particular with Japan. If you want to prove that your drug is useful, you have to prove it on the Japanese population. But I want to focus on the P7 and the H101. China, India, those were the first allegedly taking approval. But Georgia, Latvia, because the people that were running the clinical trials never released the data. We met those guys in China in 2005, 2007 actually. They were showing results, we don't even know if it was true or not. And when we asked for the data, because at this point I was working with the EMA, they never released the results. So we'll see. So let's talk about this one. TVEC, Pervec, whatever name it is, has been a game changer. And the way they designed the virus is very insightful. And it tells you a lot about how to handle those things. Okay, so the movie How to Train a Dragon, it's just Dragon en français. Please don't forget that you're playing with fire. Most of the time, the viruses that you will be using can cause a fatal disease. If it's a human, you have to be very cautious. We're not working with human viruses in my group. So you want to activate them, make them less virulent, removing some factors that can kill the cells, any of the cells that will be infected. But of course, you will be kind of weak if you want to kill a tumor cell that is resisting to a lot of things. So what you can do is to use the virus as a delivery vehicle. So clone some interesting stuff inside, just like when you changing a cell line by expressing a protein of interest. So you can arm a virus. And that's why now the dragons can, with teeth and claws and look nasty, okay? But can get to the objective, which is to kill tumor cells. So if we take the schema here, we started with HSV1. I mean, how many are we here? 80? Something like that? No, 50? 50? So I have to do my math, but most of you are positive for HSV1. That can raise some concern about antibodies that will be present in our body already against the virus. That's the first limitation. The second one is that HSV1, not the one with a fever blister, can cause encephalitis. It's quite a serious disease, okay? That can kill people. So you have to be very careful. You remove one virus, which is 34.5. 34.5 has an interesting function. I was talking about the response against the virus, and one of them is to shut down translation by E2F2 alpha. There's there's 1, 2. Anyway, EF2 alpha, yes, EF2 alpha. The F2 alpha is blocked by phosphorylation by a protein that is named PKR. PKR is a sensor of viral DNA. And so is activated when the cell is infected with HSV1. But 34.5 is a phosphatase. 34.5 is going to dephosphorylate the F2 alpha, counteracting the function of PKR, so the cell got fully, replication cycle of the virus in the cell will be killed. So if you remove 34.5, you will not kill normal cells. That's the first good point. But still, the virus will be attenuated, okay? So you add the cytokine, GM-CSF. The bet by the researchers was to add GM-CSF to attract immune cells to mature dendritic cells that are essential for antigen presentation and immune response. And so that's how they built TVEC, which is attenuated HSV1 that express GM-CSF for advanced melanoma, objective and durable responses in phase 3 clinical trial. And that was quite interesting. So if you look at the blue curve, that's a virus, TVEC. So it's basically a virus that should replicate to some extent, producing GM-CSF. Here, that's interesting. That's a phase 2 result. The phase 2, the control is GM-CSF only. So here, the benefit is the local expression, because at this time, melanoma patient, there were no immune checkpoint whatsoever. It was GM-CSF, cortisone, or stuff like that. Nothing very fancy or very efficient. And so GM-CSF was given, and the TVEC, the difference was due for the investigators to the replication of the virus and to the local production of GM-CSF. That was a huge improvement, you see, going from 20% of overall survival to nearly 60%. And then they added immunotherapies, and that was even bigger as a result. Those patients were stage 4. That's the square dots here, the blue and the reddish. And except a couple of them that escaped therapy for some reason, they were very advanced tumors. All the patients receiving TVEC plus immunotherapy got controlled disease. That was the one that granted the fast track from the FDA in 2014, and then the year after in the EMEA. For you, just to guess, how much does it cost, one injection? Yes? Oh, go ahead. That's Christmas. Again, I hope that you will never have to use that. 10,000, 20, 100, a million, a billion? No. How much does it cost a CAR T shot? You know that? 100. I think the cure is something like 400,000, 400,000, half a million, or something like that. This here, it's 65,000 one shot. That's not cheap, but I mean, it can help. It's not, I mean, you cannot have it in France because it's too expensive for the benefit compared to immunotherapies alone, but are very expensive. But you can get a shot in Germany, for instance. 65,000 euros. It's not, no, it's not huge, but anyway. And then you can do biology, super interesting biology. I've shown you some fancy animation, the virus will infect, blah, blah, blah. So yeah, whatever. Actually, there was a beautiful paper. That's one thing with the melanoma, it's a superficial tumor, so you can sample. If you work with pancreas, it's another issue. What we have here, 2 patients, at start, after infection, here in the middle. Yes, sorry, here in the middle, and then the later point. And you see that here, you have a hole because there is necrosis because of the virus. And sometimes some patients are experiencing vitiligo, or some cells get destroyed. The one with the melanocytes, even the normal melanocytes can get destroyed. So that's a cancer cell. It's a beautiful paper. And what they found, they did sampling from time to time after infection. And so they found that all the cells in the lesion were positive for the virus, but the virus was gone 2 weeks after. And these are the patients that have, long-term response for months. So what happened? They did some fancy single cell analysis. I will not comment that. I'm not able to, actually. What they found is the number of B cells, B lymphocytes are kind of, foes or friend. You never know in a tumor. But here, what they found was the B cells were going down. They didn't know why, but then they figure out that these cells were supporting tumor progression. So the mode of action is not known, but that's a good sign for going down too. Then, and the words are very important, significant increase in the number of NK cells and monocytes. I mean, that's innate in response either against the tumor or the virus, and then an increase in CD4, CD8 positive T cells, killer cells. Good news. And I think that the most important thing is this word, emergence of dendritic cells. Before injection, there were no dendritic cells in the lesions, meaning that there were a missing link between immune response against the tumor and the tumor. And emergence is very important because, it's validating the fact that this virus is encoding GM-CSF, because that's the role of GM-CSF, attracting and maturing these DC cells. So basically, that's a hit and run situation. The virus is there. It's gone for 2 weeks. What could be the reason? I don't know. No more praise, because it's a parasite. So if you kill the golden goose, there is no goose anymore, so you cannot replicate. Or it's completely removed from our immune system. But the fact is, by its presence and the recruitment of some key immune cells, it's completely reshaping the tumor microenvironment. And then the result is long-lasting response. And now I will share some insights on what people are doing, what we are doing in the lab to move toward precision virotherapy. Because to be honest, now, the people, when they started developing a strain, they want to apply that to any tumor that will respond. And the reason why is not often investigated. Let's say. That's an interesting paper that came out this year. I'm sorry. Talking a lot. That's not a virus. That's an interesting paper that came out this year in eBiomedicine. That's a quite respectable paper. When researchers took organoids, primary cell lines from pancreatic cancer, very interesting for me, actually. And they tried different strains of viruses that were already accepted in clinical trials or looking for approval. And what they try to do is a virogram, basically, just like a bacteriogram. We go to the pharmacy. And check what cells could be more sensitive to the other one. And they've been associating gene expression with positive effect of the virus. Here, for instance, galectin-1 for H1PV, a virus we are very interested in here. So the more you have galectin-1, the better the virus is behaving. And sometimes it's the other way around. For instance, OAS1 here is one of those antiviral protein. It's very, very driving negatively reovirus infection. So maybe with some more information on the tumor molecular behavior, let's say, we might be able to match a virus with a tumor type. What we've done in the lab is to go for even wider exploration. So we took some primary cells that were subjected to whole genome CRISPR screen. So this is kind of preparation where you get a population that is highly heterogeneous because there are primary cultures from patients. We try to hit one gene per cell. That's the first step. Then you have a population. then you infect with the virus, and then the virus will sort off all of this, and the cell survived. It means that the gene was broken that is protecting the cells from the infection. So vice versa, if this gene was present, it will enhance replication. That's a double negative way of thinking. That's pretty late for that, sorry. And so when you do that, you put together some screens. That's the control guides. So whatever we are doing in those cells, the proliferation is going down because of the infection. Non-validated hit because we do a first screen and second screen here for 2 genes that are not protecting from the infection. And here, that's quite dramatic in terms of protection. See that, for instance, with this gene that's been knocked out, the virus is not even able to replicate and kill the cells. And if you turn that to for prediction, if we call this host gene, I cannot disclose the name, of course, and that's in green, and the virus is in red, so you see infection for sure. These are primary cells from patients. But if you have a high host gene, you see that now the infection is boom. It's very more impressive, and the oncolytic effect is way better. And so you can have some molecular signatures that are predictive of efficacy, because more and more we are able to sample tumors to know exactly what will be the expressions of some genes of interest. Might be this one, might be antitumoral genes, and so on. And then we were talking about combining chemotherapy and virus. I will try another example. What type of immunotherapy you should combine with the virus, depending on the mode of action. It should not be this one because I've read this paper quite impressive. No, you need to know exactly why you're doing this stuff. But first you have to remind what will be the immunity going on when you have a tumor that is infected with a virus. Of course, in red, you will have a very strong antiviral immunity because those antigens from the virus are super strong compared to the neoantigens, if any, in tumor cells. So it's going to be very quick with a lot of neutralizing antibodies, a lot of antiviral T cells, most of the time CD4 T cells. Complement is sky raising, and pro-inflammatory signal, as I said, dump, pump, cytokines. You have a lot of ICD, immune cell recruitment, and then later, you have an antitumoral immunity that is more CD8 driven, and it's slower, definitely. And so we had this crazy idea in the lab. We have those models of immune competent mouse with PDAC and pancreatic cancer CDX, which are cell line derived xenograft. These are murine cancer cells within a murine host. So the immune system will be present, so we can study it. There are 2 options. We have 2 parvovirus that are, let's say, cousins or something like that. One is MVMP, minute virus of mice prototype parvovirus. This we found is able to kill cancer cells from murine origin and human origin too. Something that we've published this year, I think. And then on the other side, we have H1PV. That was one of the virus I've showed you, one of the virus that the people were using in the study with different pancreatic cancer cell lines. And that we know cannot kill cancer cells. So on the left, we have the full Monty, let's say. We can kill cancer cells, and we can induce an immune response against either the virus and cancer cells and everything. So it should be a cherry on the cake. Here on the right, we are only relying on the presence of a virus in the tube, probably with super limited oncolysis. What should we find? We look for tumor growth. We look for immune cells mobilization. All right, so we do that. Cool. on the left side, tumors are getting smaller. Not bad, okay? Still some work to do, combinations. On the right, something is going on. The tumor growth is slow. 2 injections, you have to hit more for sure. Looks like, you know, when you do vaccination, a boost, a prime and a boost. But the virus is present in the tumors, and then the tumor size, tumor weight is going down. So on the left, when you have a pretty nice response, you see everything that you want to see, just like in a textbook. NK cells going up, dendritic cells going up, CD4 T cells going up, CD8 T cells going up, and there seems to be less terminally exhausted because they are not expressing TIGIT, if I remember well. And then if you look very carefully, you will have more brownish dots within the tumors because of the infection of the virus. These are CD8 positive T cells. On the right, it's quite different, very interesting. We have, I mean, there are the same number of immune cells. The difference is exactly as I told you, CD4 T cells. Those cells are more involved in antiviral response most of the time. You have macrophages that are more M1 type. This is an immune response against the virus, clearly. But the cells are inside the tumor, and no matter what the CD4 T cells is against, it's going to secrete IL-2, it's going to secrete cytokines that will, you know, stimulate killer cells, cytotoxic cells. And what is quite interesting too is that the level of energy of those T cells is lower when you have a virus, meaning that they are more active, they are more stimulated. That makes sense. It's just like a vaccination, because the virus can replicate to a small level for sure, but the cells can present the viral antigens, means that they can prime a response against infected cells. And that with antigen spreading, or also it's been shown that small viruses antigen can help presentation of new antigens from the tumors, you can have an immune response. And this is something that is interesting. That's the cytotoxic T cells. They are loaded with PD-1, you know, this immune checkpoint. So for you, what would be the next step? If you want to use H1PV on this tumor type with cells that are loaded with PD-1, what would you add? Easy one. Come on. You had Bonosegi, no? Okay. Not yet? Ah. Immunologist already talked to you about immune checkpoint? Come on. If you have high PD-1, PD-L1, what do you want to break? The connection between the two. What should you use? Exactly. You want to use an anti-PD-1 because the virus cannot do anything on that. Collaboration, remember? The virus can induce T cells here to warm up and pimp up the CD8 T cells that are in the tumor. But at some point, those cells get exhausted. And you know about the story about cancer cells or neutrophils presenting PD-L1 that will match with PD-L1 to slow down the response. You know the story, okay? No? Yes. Come on. I would not tell Bruno. Or maybe, I don't know. So the idea was to keep the same model, but to use that's a fancy molecule. Because here, no, I have to show because we had this PD-1 moiety, so the antibody that will break the link between PD-1 and PD-L1, specifically deliver IL-2V. So it means that the cells that are completely exhausted because the cancer cells are retaliating, will be energized, let's say, by breaking the bound between PD-1 and PD-L1. And on top of that, they will receive IL-2V. That will be mandatory for CD8 cells. They got a profile, a stem-like profile, that's what the immunologists are looking for. The cells will proliferate in tumors. So we had this collaboration with Roche, and we tried to put everything together, and the results were quite interesting. This is what we can expect when, so the dark line are controlled tumors. So you have a delay in tumor growth when you infect the cells. But when you give the immunotherapy and the virus, now it's way delayed. And some tumors are not growing back. And if you look to that, so based on the mode of action, the orange-pink curve is the immunotherapy alone, but adding the virus, because they are super aggressive, and we stop giving the drug. So, I mean, the red arrow are virus, the black arrow are immunotherapies, but there is a strong delay. At some point, we are not seeing tumors anymore. I mean, we are so happy, but they are going back, it's okay. So we need to know why they are going back. We need to know if we can infect them one more time. It's like the Daft Punk. Or if we can give more immunotherapies. But that's, everything is based on the mode of action. So if one day one tumor receives PD-1 or PD-L1 as a routine treatment, we can come with our little virus, say, hey, see, it's working better. And we know why. That would be cool. And then I have to say, to finish with this. I mean, it's what? Oh, yes, it's more than enough. I love to go into ethics from time to time. When we had I Am a Legend, that's a sci-fi movie, but something happened. I mean, a few years ago. That was this woman is a researcher from Croatia, in Zagreb, Beata Alasi. In 2020, she was 49, and she found out she had breast cancer recurrence. She had a mastectomy. Sorry. So her breast was removed, and that was the second time that her tumor recurred. So second relapse, she was exhausted. She will not get another round of chemotherapy. Unfortunately, she was not doing very well. She's a biologist, and then what she did was, how can I treat myself? I mean, she heard about oncolytic viruses, but she never did it before. So she took over the literature and she made her own viruses. That's crazy. So she made two viruses. Measles virus, again, I am a legend, come on. And then vesicular stomatitis virus. That's a smart move. That's a smart move because measles virus, you might have been exposed to the virus, or if your first exposure to the virus, definitely you will have antibodies against the virus, okay? So the second or the third shot will be useless. The virus will be opsonized by antibodies that your body is making, and then it's over. By switching strains, she used another viruses, which is not human pathogen, that's coming from cattle, I think, vesicular stomatitis virus. So she will avoid this immune recognition of the virus. And this is something that John Bell in Canada, John Bell is one of the most active researchers in the field of oncolytic virus. I've tried, he tried with adenovirus and Maruba virus, two viruses that are at the extreme pole of viral evolution. So they could not raise common recognition patterns. So she did that, working on cell culture extracts. Let's get back to the 50s. And she injected herself with the help of an oncologist. This tumor shrank. Tumor. So she could go for surgery. And they found that a lot of immune cells were in the tumors. What was remaining from the tumor. Then she received trastuzumab, which is an anti-HER2 antibody. It's very common in breast cancer. And she's free of cancer for the last 4 years, I think. So, would you have done the same? What do you think about that? It's okay for you? I mean, first, it looks like a Professor Raoult clinical trial. One arm clinical trial, no control. Could be luck, okay? Probably not. But ethically speaking, it's borderline, okay? Okay, that's my life. I do what I want with my life, and I use my knowledge to save myself, blah, 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 blah. We got calls, we got emails from families that are desperate for us to try to, the MBMP, I've seen your paper, can you inject me? I have nothing to lose, please help me. I will pay you. Now, come on. So, ethics. We're working with GMOs, genetically modified organisms. I'm not going for, be careful, you can be a zombie, but there are some serious issues in that, okay? It's kind of selfish, honestly. I'm very happy that from now she's been free of tumors, but you have to consider the whole picture. I'm not, and that's weird because everything was published in the paper. She published her own results. For once, it's real own results. In viruses, that's an MDPI paper. And she was invited at the conference of oncolytic virus in Rotterdam 2 months ago. I was not there. Honestly, I have a friend, and everyone was kind of skeptical because it can do a lot of harm to the community if you have people like that breaking the rules. We don't want people to get sick. We don't want people to die. But at some point, you need to be very careful in how you end in science, because if not, it can be like all those people that think that knowledge is dangerous. This could feed those, plot people around the world. So, think about it. So it doesn't worth waiting for the FDA, AMA. If you want to talk about it.
I was reading this paper this weekend, and in the results, there is an increase of the PD-L1 expression, which was not talked or discussed within the paper.
So why not?
Yes, why is there an increase?
It could be. That's been seen before. Thank you for mentioning that. It's seen before that as a consequence of virus infection, interferon gamma is going up. And interferon gamma is inducing PD-L1 expression. That's another rationale for combining those. Yes, interferon gamma is good to kill cells, but it's one way of energizing the cells too. So that's why most of the time people are going for combination. That's weird. For me, honestly, that's weird. All right. So that's my conclusion. It's a nice picture. So if you have to, that's a wrap-up conclusion. I truly believe that viruses can help treat cancer. I've been spending the last 10 years of my life trying to do that. That's pretty cool because you have a mode of action that targets and destroys cancer cells directly, but you can also manage to involve the immune cells. And remember, our best defense are the immune cells. Don't say that to the immunologists that you will see, okay? But that's true. That's what is pretty cool is that we are trying with friends of mine to change. As a researcher, I'm not a clinician, I'm a researcher, so I'm trying to address a phenotype and not a cancer type. And I think finding patterns that are common to many cancer and might be open doors for viruses could be the solution. And clearly, what we see now in clinical trials, and I'm not talking about the last example I gave you, is showing safety and efficacy at some point. We know more and more as a cancer scientist that not every patient is the same. There is a lot of heterogeneity in tumors, even inside the patient or between patients at the molecular, cellular levels. So we may have some tools to try to target some types of cancer. And that's a huge potential for combination with other therapies, just like immunotherapy, that's for sure. But always it requires continued research, collaboration, and there's something that we are trying to capture. This is quite unique in the field of medicines, treatments, because this one is self-amplifying. It means that you have to control the dose. If you give too much, you may kill cells too fast. So replication will not be optimal. If you don't give enough, the cell will replicate faster than the virus. And for this, we are not, maybe I will talk about that next year. We are working with computer scientists, not the one that are fixing your Excel or your email books, the one that are doing agent-based model to model actually the life cycle of the virus inside the cell, and you can change many parameters to try to adjust the base dose at the best time to increase your chance of success. So that's something, interdisciplinarity is very important. I'm talking to at least care students. So, and you have to build on that because as a biologist, you cannot capture everything in a behavior. You need some help not from AI. No one is going to pick something for you, but for agent-based modeling, where you can simulate thousands of behaviors, could be very interesting. This is what we are going for right now. And that's it. So I will share the presentation with you. I think I will give it to Professor Thomas, Professor Segui, and I remember. If you have questions, if not, have a good night. Thank you.